The speaker or I don't know. Jacob. You don't know him as well. I know Jacob Steens, but he's talking now. Yeah, but he never asked me for Jacob. I don't know. But John asked me. Yeah. Okay, he's.
Good morning, good morning. Good morning, ladies and gentlemen. How was your last night? Be honest, how many hangovers? Nobody ended up at the hospital? Good. So, two little things to start off. First of all, still a fondue. There are a couple people coming up to me and saying they forgot to sign up the second fondue list after we lost the first one. Please, because the cows are waiting for getting milk. Sign up back there if you haven't signed the second list. Does that make sense? If you only signed in once yesterday in the morning, that list disappeared. Someone stole it. So we made a second one, remember? And you signed in. And for you guys who didn't sign the second one, please sign at latest next break. The second thing I need to talk about is at 12:30 we have an ultrasound central line workshop, and it's not just a regular workshop. They're truly the best of the best in the world. Right here, Hotel Alex, this conference room, 12:30. Ultrasound central line workshop. Thank you.
Sorry, just one thing, Ollie, on that workshop. It's 12, not 12:30, straight after the sessions. So, good morning and welcome back. So the first thing is, I believe this is going to be someone who's Danish, has left an iPad here. If you'd like to claim it, you'll have to claim it in Danish so that we can return it to you. But I'll leave that with the guys at the back, so we can pick that up later. Right, so this morning, hopefully you've all enjoyed the mountains and everything else. We're going to go straight back into hardcore practical science for us. So our first speaker is Bernd Bottinger, who is renowned as having been a past chair of the European Resuscitation Council and worked on its science and research division, and is the current treasurer. But he's also the chair of the German Resuscitation Council, and he's going to talk to us with his wealth of experience and knowledge about the updates to the CPR guidelines and what that means for us. But welcome, Ben.
Thank you very much, everyone, and good morning. Hope you're all doing very well. I'm very happy to be here. Thanks for inviting me to this beautiful environment and this high-end conference. So, update on the new CPR guidelines in 30 minutes. We worked on this for several years and hope it will help the patients. And this is one of the most well-known patients. You know him. Who is that? You know? Christian Eriksen. He will now start his second part of the career because he's working in UK from the next weeks on as a soccer player again. And what happened to him is happening to 1,000 to 2,000 patients per day in Europe, every day, all over the year, and only very few are as happy as he was and is. Oops, I have some potential conflicts of interest. Some of them have already mentioned. Most of them are associated to my engagement in different organizations, internationally and nationally, and I also get some fees for lectures over the last years. The most important chapters of the new guidelines in my eyes are the two which are new, which is epidemiology and system saving lives. And with all the other things, not so much new evidence was seen over the last 5 to 6 years. So most of what you already know on the process of cardiopulmonary resuscitation is still valid. And I will primarily focus on these two chapters, but also on the other ones during my talk. Epidemiology. The rate of bystander CPR varies between and within countries from 13 to 83%. So there is a huge amount of differences in the rate of bystander CPR. We have learned already yesterday from our Danish colleagues and many others that bystander CPR is a key issue for survival, and this also happened to Christian Eriksen. He was resuscitated from the beginning, and that's the key for success. Also, the survival rates at hospital discharge are varying from 0 to 18% in Europe. And I can give you an example from Germany. We are anywhere in between 40% bystander CPR rate, 11% overall survival, which is just intermediate, so we can further increase and develop in Germany. This was out of hospital cardiac arrest. In addition, we have in-hospital cardiac arrests a lot around Europe and all over. In the European Union, we have 350,000 out-of-hospital cardiac arrests and 250,000 deaths by in-hospital cardiac arrest. So it is 1,650 deaths per day. So this is the third leading cause of death in so-called developed countries. Killer number 3, and it's worth to think about that. System saving lives is the second most important chapter in the new guidelines. And in this chapter, we have delivered 5 top messages, system saving lives. And you can see them here, and I will focus on all 5 very briefly. First one is raise awareness about CPR and defibrillation in your community and in your nation and in your environment. You know, we all know the chain of survival. And you probably know the new chain of survival, where the first chain and the second chain are the most important. Think about Christian Eriksen. First and second chain are most important, much more important as compared to what we are doing in the hospital. It's not so important what we're doing there. And the sizes of these chains are based on real scientific numbers. So this is really scientifically based. That was one of the reasons why we installed in Europe already 2012 the European Restarter Heart Day. And in the world 2018 we had the first World Restarter Heart Day to raise awareness about CPR and defibrillation. Because we know, not only from Denmark but also from many other studies and countries in the world, that if you start CPR very early, you have 3 times more survivors with lay resuscitation. 3 times more survivors with lay resuscitation. World Restarter Heart, we had a lot of activities. 2019 and 2020 was the first year of the pandemic. we asked the Vienna Philharmonists Andrew Lloyd Webber and others to come up with songs that had the right rhythm to resuscitate a patient. The Vienna Philharmonics helped us with the Radetsky March, and we had a lot of activities in social media. The year before the pandemic, we reached more than 206 million people, and we trained 5.4 million in lay resuscitation all around the world. Only in India they have trained 500,000 lay people how to do CPR. We also had the help of the International Red Cross. They delivered toolkits all over the world in 192 countries of the world to help us to spread the message of how easy lay resuscitation is. I didn't know during this time how many countries we have in the world. Does anyone know the number of countries we have in the world? It's 194, so we only missed 2 countries. This is the World Restart a Heart map. We had all 7 member councils of the International Liaison Committee on Resuscitation. We had the European Society of Anesthesiology, the World Federation of Societies of Anesthesiology, the Red Cross, intensivists, and many others that helped us. So thanks for joining. If you have joined, anyone in the room who joined this activity? Maybe this year. It is every year on October 16 or around. And who in the room is an anesthesiologist? Most of people here in the room are. What is October 16 for anesthesia? Do you know this? It's the World Anesthesia Day, so it's easy to remember. World Anesthesia Day is also the World Restart a Heart Day now. Number 2 is use technology to engage communities. We already heard about that during this conference, and you can also send first responders during the pandemic if they have adequate personal protection equipment. We have many studies showing that if you have first responder systems, there are many different ways to establish a first responder system, but the most important thing is you must have a first responder system. They may reach the victim in more than 50% earlier than the regular emergency medical service system. My question to you now is, who is in his area has a first responder system? So a lot. But nevertheless, there is place to improve. All over Europe, implementation is probably rudimentary. Number 3 is kids save lives. 2 years ago, I spoke about this topic here in Zermatt. This is our logo. So what we think is, it is important to train school children in cardiopulmonary resuscitation. So they must learn it before puberty, and then it is for them as bicycling or swimming, so they will never forget. This is one of the activities we had in Germany several years ago. This is the Kids Save Lives logo for the pandemic times. We have the support from the World Health Organization since 2015. We approached them and asked them for help, and now they recommend school children education for 2 hours per year, starting at about 10 or 12 years, as long as they go to school. And this is the European map of CPR education. Based on our activities, school children education in resuscitation is now a legislation in 6 European countries and a suggestion in another 23 European countries. Again, a question to you, whoever has been able and had the chance to educate school children in cardiopulmonary resuscitation. Okay, thank you very much. If you start with this, you will never stop. You will get addicted to this because it gives you so many things back from their enthusiasm. So try it. Our suggestion for kids, you can even start in the kindergarten with this education and train them doing check for signs of life and call the emergencies. So we have seen very nice examples from 4-year-old young people who checked for signs of life and called the emergency by using smartphones and Siri. at the age of 10 or 12 years, they have enough physical energy and power also to do cardiac compression. So 10 to 12 years, check, call, compress, and with 14 to 16 years, they also are able to learn and to provide ventilation and the application of an AED. Check, call, compress is our international message. Nevertheless, as we have seen here in this round, implementation is not adequate. It is still rudimentary, and we all can work to improve this. Think about the first chain in the chain of survival. Number 4, cardiac arrest centers. This is the German logo for cardiac arrest centers. We have a lot of systematic reviews and studies showing that if a patient after an out-of-hospital cardiac arrest is received by a specialized center where they can do 24 hours, 7 days per week, PCI and many other things, then the chance to survive an out-of-hospital cardiac arrest is 2 times higher than if someone is coming to a regular community hospital. We know that at least 50, maybe 60, maybe more % of all out-of-hospital cardiac arrests are due to an acute myocardial infarction or due to acute coronary syndromes. And that's probably one of the reasons why this is improving overall survival. So 2 times more survivors with cardiac arrest centers. In Germany, the German Resuscitation Council started 2017 with this approach. It's in the international guidelines since 2015. In the meantime, we have close to 100 audits. You can see the map of cardiac arrest centers in Germany. And it's not only in Germany, but in German-speaking countries, also in Switzerland, in Bern, and in Austria in the meantime. Implementation, not bad in German-speaking countries. In Europe, it's in progress. So we are currently working with the European Society of Cardiology and the European Resuscitation Council and other organizations to establish a network of cardiac arrest centers also in Europe. Number 5 is dispatch assistant during CPR, better known as telephone CPR. Can I again ask you who in his area is doing or is receiving telephone CPR? So many are doing this. Nevertheless, there's obviously room to improve. Number needed to treat for 1 additional survivor is 7. So you need to do it for 7 times to have 1 additional survivor. And if you're doing telephone CPR, you probably need to do it for 10 minutes, maybe 15 minutes. So with 70 minutes or maybe 90 minutes time invest of a dispatcher, you can save 1 life. And this is just extraordinary, outstanding. Nevertheless, implementation is mixed and can be improved. And this is one most recent example from Lübeck, which is in the north of Germany. This 43-year-old, I think, man collapsed, and his son and his daughter, the son was, I think, the daughter is 7 years old, the son is 10 years old, he is 10, he's 7. He collapsed, the son called the EMS, the dispatcher told the 10-year-old how to do cardiac compressions, and she waited outside to receive the EMS and to guide them to the site of the incident. And he survived, very luckily. So even 10 years old young people can be the partner in telephone CPR and can do CPR even if they have not known that before. As one of the gifts, they were allowed to visit the EMS and to drive in one of the EMS cars in Lübeck in Germany. So what do these animals do in a talk about the new CPR guidelines? Do you know how these animals are called? That's the big 5. And what I have presented to you was the big 5 in cardiopulmonary resuscitation. This is much more important than any drug, than cooling or not cooling, than anything else. And we have published an editorial on the big 5 strategies for survival following out of hospital cardiac arrest. And I will repeat it very briefly. Here, this is the intervention. This is the estimated impact on survival. So increasing lay resuscitation rates up to threefold increase in survival. Telephone CPR, 2 times increase in survival. Same with first responder systems and with experienced ALS teams and also with cardiac arrest centers. So these measures are the most important to improve outcome in the killer number 3 in industrialized nations. And this fits very well to the 5 most important bullet points in the guidelines chapter on system saving lives. What else is important? Very briefly, very fast, basic life support. 5 top messages. Number 1 is check, call, compress, and give 30 chest compressions, give 2 rescue breaths, and continue in this way. This is basic life support. Top messages for advanced life support. So one of the nice things in the new guidelines is that we have these infographics always pointing to the most important 5 bullet points in the guidelines. And as you can see here, priority 1 is compress without any interruptions, defibrillate if indicated, and look for reversible causes of cardiac arrest. Priority number 2 is cardiac arrest prevention, use of medical emergency teams and all the other things. Priority 3 is oxygenation. Use different steps. Don't intubate if you are not skilled with intubation. Use other supraglottic airway device or back valve mask ventilation. Only use those things for oxygenation that you are very used to do and where you're familiar with. Priority number 4 is drugs. Adrenaline, no doubt about that, after the Paramedic 2 trial. New in the guidelines is that amiodarone is adequate to lidocaine, or put it in the other way around, lidocaine is adequate and is as effective as amiodarone. So you do not need to use amiodarone anymore if you have lidocaine on your car. Very new studies showing similar effects. If you have a high suspicion of pulmonary embolism, please use thrombolytic agents during ongoing cardiopulmonary resuscitation and do CPR for 60, 90, maybe 120 minutes to give the thrombolytic agent the time to act. Priority number 3, you will hear in the next talk a little bit more about that, is eCPR or ECMO. We have a new randomized control trial showing that this is most effective. This is the algorithm, intravenous or intraosseous access. We have some data that intravenous is better than intraosseous, so please be trained in IV access. Identify and treat reversible causes. Think about the special circumstances. Special circumstances is the most volumed chapter in the new guidelines. It's very interesting to read more about that. Post-resuscitation care, last topic in my talk again. The 5 top messages. Priority number 1, oxygenate to oxygen saturation from 94 to 98%. PCI, if indicated, if you have ST segment elevation, put the patient to the PCI lab. If possible, go to a center. If possible, go to a cardiac arrest center. Temperature management, I will focus on that a little bit further. Guidelines have been published in March before the TTM2 trial was published. So in the guidelines, we recommend 32 through 36 degrees for at least 24 hours. No fever for 72 hours. Prognostication not earlier than 72 hours, and rehabilitation. This is probably also very important. We have nice pictures in the new guidelines. You will enjoy them. Prognostication not earlier than 72 hours. Use at least 2 of these criteria. Do not use only NSE or only pupillary or corneal responses. And then mid-2021, the TTM2 trial has been published. Who has read at least the abstract or the study of the TTM2 trial? Okay, a lot of us. And I will go to this a little bit further. So 1,900 adults with coma after out-of-hospital cardiac arrest have been enrolled in the TTM2 trial. And what is probably most important is this. Bystander witnessed cardiac arrest, 90%, more than 90%. Bystander performed CPR. Think about Christian Eriksen. He also received bystander CPR. Around 80% shockable rhythm, more than 70%. In my country, we have 21% shockable rhythm when the first EMS is arriving. So we have other patients than those that have been enrolled in TTM2. Therefore, I'm putting a question mark here. These are the temperature curves in the TTM2 trial, which is very similar to the temperature curves in the TTM1 trial. And what is most important with this figure is that you can see here hours since randomization. And from cardiac arrest to randomization, it was 132 minutes in the TTM2 trial, so it was more than 2 hours in this trial until they start randomization. And then after 7 more hours, so after 8 or 9 hours after the cardiac arrest, they have reached the target temperature in the TTM2 trial, which is very late. So we have a lot of animal experimental studies showing that cooling is effective after global cerebral ischemia or whole body ischemia and reperfusion. But does anyone in the room knows one animal experimental study showing any effects of temperature management if the temperature is reached more than 7, more than 8 hours after the event? Do you know a study? That is probably one of the problems in TTM2. But also one of the reasons why the survival rate is 50% in both groups, so very high survival rate. So there have been many Christian Eriksens in this study probably. No differences in any subgroup. Downtime before start of CPR. In TTM1, in TTM2 it was not reported. Downtime 1 minute until start of CPR. In most of the cases, start of CPR was lay CPR, but nevertheless we know that lay CPR is most effective. And after 1 minute downtime and 7 or 8 hours until cooling, we may not expect so much effects of any kind of temperature management. Was there a therapeutic window? Are these patients our patients? I have already mentioned that target temperature was reached 7 hours after cardiac arrest. By the way, who in the room is treating post-cardiac arrest patients in her or his ICU? Okay, several here. Thank you very much. Nevertheless, we had just published the ERCE-ICM guidelines on temperature management 2 weeks ago in resuscitation and in intensive care medicine. And here we do not recommend any temperature anymore. We said all is possible. There is currently insufficient evidence to recommend for or against temperature control at 32 through 36 degrees Celsius in any populations of cardiac arrest patients or using early cooling, and future research may help elucidate this. We have analyzed all the data on cooling in out-of-hospital cardiac arrest patients further. This has not been published, but it is already available as in print version for us as the author's proof. It will be published in a few days, hopefully. And the message is, in our eyes, the effectiveness of target temperature management following cardiac arrest may depend on bystander cardiopulmonary resuscitation rates, as already pointed out when analyzing the TTM2 trial. This is the absolute benefit per 1,000 treated patients, and this is the percentage of bystander CPR. TTM1 and TTM2 are here. Bystander CPR 70, more than 80%, no effect with regard to benefit per 1,000 treated patients. But all the other studies with lower bystander CPR rates, not so many Christian Eriksen in these older trials, and maybe also in our regular patients, at least in Germany, you see an effect which is very much related to the rate of bystander CPR. So this is, in my eyes and in our eyes, a very important message. Think about Christian Eriksen. He sent Instagram posts in the afternoon after his cardiac arrest. So these patients do not need to have any very highly sophisticated temperature management following this insult. There's another pre-proof just published, this is online available in Resuscitation, about the impact of mild, moderate, and severe encephalopathy diagnosed by EEG on the effects of temperature management. And as you can see here, if you have no or only very mild insults, there's no effect. If you have severe insults, there's no effect. But if you have moderate encephalopathy, there is an effect. So in doubt, we are cooling our patients even after TTM1 and TTM2, again here highlighted in this graph. We use temperature management for at least 24 hours, and we start cooling not after 7 or 8 hours, but as fast as possible. We have further algorithms and many other things very nicely presented in the guidelines. So if you are interested in many other topics, please go to the guidelines. They are online available, several hundred pages, and I don't have the time to go into details anymore. My summary is everyone must save lives. Kids save lives, telephone CPR, first responder, ALS, post-resuscitation care and prognostication are probably most important. Politician support is necessary for at least the big 5. Lay resuscitation, cardiac centers, Kids Save Lives project and others. We need the help of the politicians. These are the big 5. And please join us on World Anesthesia and World Restart a Heart Day this year if you like. We can save a lot of lives in Europe and all over the world.
It only takes 2 hands to save a life.
And we also have good collaboration with the Brazil anesthesiologists. They also have Kids Save Lives programs, and it is mandatory in Sao Paulo, in the whole state of Sao Paulo, to educate school children in cardiopulmonary resuscitation. And we also trained the International Space Station astronauts in emergency medicine in my department. By the way, here is Switzerland, this is Italy. Nice weather over there. Thank you very much for your attention.
Thank you so much, Ben. That's absolutely fascinating. Are there any questions from the audience? Yeah, all right, we'll come down there.
Hello. You mentioned briefly earlier that there was some evidence in some of the studies you've done that IV was superior to IO for cardiac arrest. I just wondered if there were specifics as to why that might be.
So we have meta-analysis and systematic reviews showing that the effect of IV is a little bit better than the effect of IO, particularly when you are focusing on epinephrine and some other drugs that you are administering during CPR. Pardon?
Do you know why?
Oh, why? That is the evidence. There are many speculations why. One of the reasons is probably that we know from several studies that the IO access, if you're doing it in the out-of-hospital setting, in many cases it is correct, and in many cases it is not correct. You're not in the bone marrow substance of the bone, and you probably need to flash, even if it is in the correct position, with a lot of saline or other infusions, which might not be made. Another explanation is that IO access is regularly performed as the 3rd or 4th line treatment after having several unsuccessful attempts at IV line. That's also one of the reasons why IO is probably not as effective. But these are only speculations. Fact is, IO is less effective than IV. So all should be trained very well in IV access.
Thank you for your presentation. Regarding adrenaline, we are experienced pre-hospital providers. If I go to a 10-year-old kid weighing 50 kilos and a 30-year-old woman weighing 50 kilos, how much adrenaline should I give the two patients?
1 milligram every 3 to 5 minutes. Yes, I would do this.
Any other questions? Oh, yeah.
You mentioned that kids are more important regarding CPR. Do you know if there are any recommendations about psychological treatment of kids, especially if CPR was not successful?
Yeah, we had this discussion. Also, the two kids are a little bit that I have shown you after telephone CPR are a little bit. The mother told me they are a little bit afraid, they are a little bit traumatized. We have discussed this with psychologists, and the psychologists are telling us that kids are not traumatized by CPR, but they are traumatized by the cardiac arrest. And this, in a cardiac arrest of a family member of the father, it is just fate, and you cannot avoid this. That is the reason for the trauma. And if kids are able to do something, it is always better than if they only stand there and are not able to do anything. That is at least one of the things we have discussed. So there is always some kind of traumatization, but it's not because of CPR, but it's because of the cardiac arrest. And if you are trained children in cardiopulmonary resuscitation, they are totally empathic. They don't have fear, totally different to adults. Maybe all in the room who are doing CPR training in kids can support this. So there may be a reason for traumatization, but it's always the cardiac arrest, not the CPR. That's my summary.
Thank you.
The last two questions at the front here, and then sadly we need to move on. Joe, is this going to be about circadians?
I mean, there is a circadian survival to cardiac ischemia, but anyway. No, I was going to ask, with rewarming, obviously it's about the basal metabolic rate increasing, and animals that rewarm after hibernation, they do it quite quickly, but they don't do it without jacking up all their sort of reactive oxygen stress defenses. So I just sometimes feel with the rewarming, we just heat them up and accept that we're going to blitz with reactive oxygen species and don't have something to go alongside with that. And yeah.
Yeah, good question. We don't know anything special about this in humans. The only message is don't rewarm as fast as hibernating animals are doing it. So I think we have some animal experimental data after global cerebral ischemia. I mean, hibernating animals do not have global ischemia. They always have some kind of circulation, and hypothermia is protecting. So these models are really different. After cooling in patients, don't rewarm too fast. At max 0.5 degrees Celsius per hour, and maybe less.
Dr. Berger, thank you for an excellent lecture, and I really would like to congratulate you on your important work in developing European guidelines. My question is, you talk a lot about TTM, but in my mind, it seems like TTM is only for substandard care. Shouldn't we focus even more? I know the ERC are focusing a lot on the basics, on setting up a high standard for resuscitation of cardiac arrest patients, but shouldn't we focus even more on doing the basics right instead of doing TTM?
That's what I said at the beginning. Remember the chain of survival. The first chain is the most important. Second chain is also very important. And the last chain, which is TTM or no TTM or prognostication, is a very small one. So the most important things are the big five, and all the other things are much less important. Thanks for summarizing that so nicely. Thank you very much.
Absolutely brilliant. Thank you, Ben. That was a fantastic talk, and please carry on with these discussions afterwards in the breaks and at the bar in the evening. Thank you. So, it's really nice to have a theme running through the morning. So I'm going to try and say this name correct. Now, just tell them all that I got it wrong if I do. But Domagoj, almost. So Domagoj is an anaesthetic consultant in the cardiac intensive care unit in Freiburg, which is a town I've visited many, many years ago and is absolutely beautiful. I totally recommend to you. But they're doing something really, really cool there. They are doing eCPR on the streets of Freiburg in selected patients. And I think as a segue from absolutely getting the basics right, where, you know, if I had $1 to put into trying to save people from cardiac arrest, I'd probably put, 70, 80 cents of that into teaching people to do bystander CPR. But then for that small group that end up in refractory VF or in other things, that's where you want to have these sort of the icing or the cherry on top of the cake that's really going to make a difference to this group. And I think that's where these sort of targeted things like eCPR, for me, are really, really exciting, because it's where, we can add something in as medical professions that really can, well, hopefully can make a difference. But I will let you speak about this.
So thanks for the very beautiful introduction and for the effort to pronounce my name. Very exciting for me to be here. Hi everyone, good morning. I have been following this format ever since it started, and I was always wishing to be part of this, so here I am. Great thing. And my talk will be on From Bridging to Treatment, Old Paradigms and New Insights in Cardiopulmonary Resuscitation. And just in case it's hard for you to remember the name, Joanna yesterday said she's Joe, so I'm Doe. And the talks also have some overlaps. So that's my conflict of interest. Until 6 in 2020, I was a part-time employee at research and development in a startup company that's a spin-off from our university hospital in Freiburg, and that exactly deals with some topics of the talk. They are developing extracorporeal perfusion devices for whole body reperfusion. Also, I'm an anesthetist and intensivist by training, and yeah, I would leave it to your discretion whether you consider it as a conflict of interest that I'm actually on the payroll of cardiac surgeons. I would say it's a confession of interest. So these are the learning points. We are actually bridging. Second thing is, how long can the brain actually survive after ischemia? We heard some news yesterday about this, anti-huge potential that might be there. We'll go a bit into ischemia reperfusion and no reflow, way less than Joanna did yesterday. Luckily, she took this on her part. Then we'll talk about cardiac surgery and CPR. It's a close relationship, and from bridging to therapy. My name, by the way, is from Croatia. Beautiful country. How many of you have been there already? Okay, not so few. And if you want to travel from north to south in Croatia, there is this beautiful Adriatic Highway. And this was, for a long time, the main route from north to south. And on this main route, there was one very important bridge over this strait here. So the Maslenica Bridge. And as it was on the main route, if it got blocked, then the supply from north to south got blocked, and all of this area here was ischemic. Oh, it ran out of supplies. And that's what happened in the Croatian Independence War. So that bridge got destroyed. And if I wanted to go and see my grandparents, and we wanted to travel from north to south, we had to take a ferry way up there north, a ferry, and then travel by other streets. That means we lost a lot of times bypassing this area of blockage. I think you get in the analogy. So in these terms, not only when traveling, but also when talking about cardiac arrest, time is toxic. And we want to shorten no-flow times, and we have to put and go on putting many efforts into shortening these no-flow times. But what we actually do, we must admit, until today, is bridging. That's a pontoon bridge. Once the Maslenica Bridge was destroyed, they built a pontoon bridge. It's a floating bridge. As you can see here, it's not as robust. It only brings the most important stuff, so the most important things can cross this bridge, and you hopefully get to the other side. That's what we do in CPR. We have the collapse, we do CPR, and we hope we will get ROSC as soon as possible. But it's not as robust. We have, we have only 30% of the cardiac output we would actually need to perfuse the organs right. And when then we are trying to get even better, we can try to do what we do as good as we can and to take all technological means to improve this. And then we are talking about targeted CPR maybe, or tailored or goal-directed CPR. We can look at the coronary perfusion pressure using diastolic blood pressure. We can use ETCO2 as a feedback, and we can even consider how the monitoring changes in art lines when using mechanical CPR. No surprise, you have seen this talk in 2018 here from Per Olaf Berve, and I have nothing to add to this. So the organizers asked me if I could tell something about diastolic pressure and CPP and stuff. I have nothing to add. That talk is absolutely excellent, and I can only recommend that you listen to this on the target page here. So we are still just buying time, as disappointing as this may sound. And even low flow time is bad. You all know these curves. This one has been cited up and down. It's from a colleague in my hospital and their working group about the impact of eCPR or conventional CPR in prolonged cardiac arrest. And no surprise, the longer you are into the arrest, the worse things get. So survival, especially neurologically favorable survival, drops. This one is hot off the press from a Korean working group recently released. And again, the curves look quite similar. So the longer you need, the worse things get. What also has been shown by the group in the US, by Bartos and Yiannopoulos, in all of their research into prolonged cardiac arrest, they again and again show that the longer you're into the arrest, you have a progressive metabolic derangement. You all know, and you all will find this clinically, that the longer you are doing it, the worse the pH gets, the more lactic acid accumulates, and so on and so on. And maybe through all these efforts, even using my pet peeve, ultrasound, and pit crew training, whatever you do to improve your CPR performance, we're still bridging. We still hope we get to the other side as quickly as possible. This is the rebuilt Maslenica bridge. More robust, but it's still a bridge. We still have the collapse, we do CPR, we hope for RUSC, and we hope to get to the hospital to definitive diagnosis and treatment in a cath lab. So the bridging is also in our hands. Now looking into more basic and experimental science, science says time is relative. Not only Einstein said this, but also animal experiments. And I have tried to put this down for you here in the graph. So this is untreated no flow time. So that is, you called it downtime, Professor Böttiger. However you call it, the time when someone collapses until CPR begins. And we all say, yeah, like about 5 minutes, more shouldn't be, more is not well survivable. And all those animal studies, you can look at all these years here, have tried longer untreated no flow times, and in their experimental settings, they have shown that these animals can survive, and not only survive those no flow times to the brain, but they recover neurologically well. And the deeper you get into this literature, the more surprised you are. Let's look at this further. Here is a study that is not much above our 5 minutes paradigm, but then here you have 15 minutes. This is one from our working group in Freiburg, where you have 20 minutes of untreated no flow time until something happens. And then in 1987, but this group was active way before, they published an experiment with a cat. It's not Schrödinger's cat, it's Hossmann's cat. And yeah, it's from the Max Planck Institute in Cologne. Professor Böttiger, you know it, you have been there as well. And the cat, they cut the blood supply to the cat's brain by clamping the arteries, the upper thoracic arteries, for 1 hour. and they even lowered the blood pressure. So they made sure that this brain had no blood supply. The rest of the body was supplied, but the brain not. And even after 1 hour, then they reperfused. They did some things like increasing blood pressure very highly unto 180 millimeters of mercury. And after that, the cat recovered. And it not only recovered a bit, but it recovered fully. And it was even taken out for a walk around the institute for 1 year or something, until they then wanted to know something about the histopathology. And that, sorry for that. That was the end of Hossmann's cat. Okay, now, amazing data, and it's not so new. That's why I said old paradigms, new paradigms, it's not so new. So, and then in 2019, something more amazing happened. There was this working group from Yale, from neuroscientists, and they took pig brains, whole pig brains out of pig heads, and started reperfusing them only after 4 hours. This was published in Nature, and this was, as you can imagine, very much discussed across the world, and it raised many questions, also many ethical questions, but I'll leave you with that. So, what does this tell us? Clinically, we all see what we have seen this morning in the lecture on the guidelines. The numbers are still bad. No flow times of a few minutes lead to a bad outcome of cardiopulmonary resuscitation, but science tells us there may be more potential. Okay, so that's our current paradigm, and these are the studies that by far surpass this old clinical paradigm. One factor may be ischemia, reperfusion injury. We have heard and talked a lot about it already, so I don't need to get in too deep into this topic right now. And the paradigm is quite clear. Ischemia happens, it does some injury, and you end ischemia by starting CPR, by doing some reperfusion, although in quite an uncontrolled way. And by instituting reperfusion, you do further damage. So how does this happen? Ischemia itself creates a toxic milieu, and that leads not only to the depletion of energy substrates, but also to the activation of pathologic pathways. And with the reperfusion, the highly reactive oxygen species and other species, they act quite aggressively, and they further damage membranes and biomolecules and the mitochondria. Another process to be considered is no reflow. That's what the studies with the cats showed very well. No reflow phenomenon means that you can restore macrocirculation. You can have good flow, good blood pressure in your major vessels. If you do an angiography, you will even maybe find good perfused vessels in the whole brain regarding the major vessels. But microcirculation remains bad. And that means that you have vascular constriction, cellular edema, stasis, erythrocytes plugging in the microvessels, and that means that the tissue is still not perfused very well. Nowadays, we have a means to observe this live. This is called vital microscopy or sublingual microcirculation assessment with a camera, and this is a work from a neighbor working group. I think the resolution is not too good to see, but if you follow this, I'll go back. So this is like after CPR, and you have well-perfused big vessels, here even less, and here you have also well-perfused big vessels and less perfused small vessels. Okay, let's get back to that bridging theme. Not too far away from this bridge place, from Maslenica, there is the beautiful city of Zadar at the Adriatic coast, and this gentleman is actually from Zadar. It's Nenad Shestan, and he is the working group leader. He's a neuroscientist in Yale, and their group performed this famous pig experiment. And this is how their publication is called: Restoration of Brain Circulation and Cellular Functions, Hours Post-Mortem. Their methods were, they collected these porcine heads and extracted the brains with the help of neurosurgeons. This is quite tricky, getting them out of the skull intact. They connected them to a brain X perfusion system, and they perfuse it with a brain X solution. And what they also had in the perfusion device was a pulsatile high blood flow with a high pulse amplitude. They had many protective constituents in their solution. Acellular solution, so they had no blood cells in it. They had oxygen carriers. They had inhibitors of apoptosis, of necrosis, of radical scavengers, and many of constituents that you cannot infuse into a human or into a whole body. But for these brains, it was pretty feasible. And what they got is, even after 4 hours of no perfusion in the brain, they got cellular activity. They even showed action potentials. They showed some vasoreactivity, and they showed that macro and micro perfusion in these brains was restored. So very exciting study. And if you look at the first author, it's another Croatian name, and you know Croatian words by the missing vowels. So you will be one of the few people in the world who will pronounce the first author right. He's called Vrselja. Okay. Very important point to the authors was, never was there an organized EEG activity in these brains. So they wouldn't have allowed for that. They even had added suppressants of EEG activity, and they had anesthetics ready. So if there anything like higher brain functions would have occurred, they would have stopped the experiment. So just to be clear on this. Our own working group did something similar. That's why we were so excited about this study. That's why we got in touch with them. That's why we wrote a review also in Nature to put all these research results together as a review. And this is what we were actually doing and are still doing. We have 20 minutes of untreated normothermic no-flow time. Then we do 60 minutes of reperfusion. Then we wean the animals not only from cardiopulmonary bypass, but also from the respirator, from anesthesia, and we follow them up for up to 7 days to look for their neurologic recovery. And the reperfusion method that was developed there is called controlled automated reperfusion of the whole body, or CAL. And these are what we use. It's also high pulsatile blood flow, online BGA, oxygen, CO2 titration, high osmolar priming, hypothermia, even calcium depletion, and if needed, secondary cardioplegia. And we have seen also impressive survival. 9 out of 10 animals do recover within 7 days, fully neurologically intact. I'll go over these studies. It's just to show you there are a few, and I'll add these in the show notes so you can read this. Then, on the initiative of my estimated colleague Jan-Stefan Poth, we took these to the PET scanner. So wholly instrumented pigs with extracorporeal circulation running, taken to the PET scan. And there you can observe this is baseline brain perfusion. This is after 5 minutes of reperfusion. So you see the cortex is still not perfused. This could be a no reflow. And after that, you even get to some kind of hyperemia. So you definitely overcome the no reflow. So we're also talking about preventing further damage. And when you talk about preventing damage, I'll borrow this from my working group leader, and he always takes this example. So when your engine lamp lights up on your car, what do? Of course, you pull over and ask for assistance, and you turn down the engine. What do we do in cardiopulmonary resuscitation? We give 1,000 micrograms of adrenaline, so that's fuel, and we expect the heart, to do all the work to reperfuse an ischemic whole body. So that definitely increases complexity. And the point I want to make is, if we want to get hold of all these complex processes, we will need to get into patient physiology more and more deeply. And if only we had this central access to patient physiology, wait, we have it. Yeah, this is an extracorporeal perfusion cannula, arterial cannula. The veins are even bigger. So what we have is a very much of an access to central patient physiology. The device consists of a pump, of a membrane lung, of oxygen supply, and that's basically it. Still, it's a bridge, because someone even wrote it down. eCPR is a bridge to means it should not be considered as salvation. And if you do it like this, we again only take it to get to the cath lab alive to reopen the coronary artery. Now, just consider, this is a fully functional membrane lung. That means whatever you connect to it gets into the blood. Now, if you only carry one bottle, because maybe you're in a mobile eCPR unit, if you carry one bottle, only pure oxygen, how much PaO2 will be in the patient's blood upon reperfusion? 500 or something. So definitely hyperoxia if you don't take care of that. So you should mix the gas and you should titrate oxygen. Just to give you an example how the only use of bridging doesn't help maybe. And the point I want to make is when you're talking to cardiac surgeons and you say, how can we get hold of ischemia reperfusion injury? They say, we do it all day long. We do it on purpose. We stop and restart ischemic organs all day long. So what can we learn from them? Does anyone know here what the surgeon wants when he says, give me a heart shot, please? Anyone heard of it? Heart shot? That's the cardioplegic solution, part of it. So this part here is mixed with blood, and you use it to stop the heart so that you can do surgery on it. And this one here, the heart shot, is infused into the heart to restart it again. And this heart shot has energy substrates in it. It has buffer. It normalizes ion balance. That means they use a special thing that the cell sees first. The ischemic cell sees first this solution with blood, and it's another thing than uncontrolled reperfusion. And you can even apply this to an ongoing ventricular fibrillation. You can use cardioplegic solution, and you can give a potassium bolus, and this is a pharmacologic defibrillation. Not quite new, this idea. We also use this. And in Paris, they are even doing this without extracorporeal circulation. So it's an ongoing study where they give a 20 millival potassium bolus in refractory VF. I think they are actually recruiting. Someone here from Paris? Okay. So let me conclude. We need to continue bridging. Clinical results are unequivocal. That means we need to go on shorten no-flow times. But the brain might potentially be more resilient to ischemia reperfusion injury than we ever thought. We need to overcome ischemia reperfusion and no reflow. And we should definitely better leverage the possibilities of extracorporeal circulation because it is such a central access to the patient's physiology where we can modify many, many things. And therefore, we should move from bridging, also in our hands, in our mental concepts, to therapeutic uses of extracorporeal circulation in such advanced measures. So I conclude with that, just giving you a glimpse at this restored bridge. And if you look closer, it's two bridges. When they restored the bridge, the first they built was a motorway and you have to pay for it. So the macro circulation went well, but the area around, they were unhappy because they had to pay the tolls now, the regional population, just to cross the bridge. So they built a second one, and they restored microcirculation. Okay, so I'll be happy to take your questions, and I'll make a short shout out to all the colleagues from the working group, and also to my sister-in-law, who's a designer and helped me with the slides.
Brilliant, thank you. What a fantastic and an insightful talk. What questions do we have from the audience? Well, so can you tell us a little bit about what you guys are doing in terms of eCPR practically in Freiburg? Are you starting to roll it out on patients as they come into the ED, or?
Yeah, we have an in-house eCPR program for a long time, for many years now running. So the cardiac arrest patients are brought to the hospital from OCA, and also in hospital, of course, we apply it. But we now, since some 2018, we have started a program in the streets, very much like in Paris. So we have a car that deploys the whole eCPR team to cardiac arrests.
Fantastic. And one thing I'm always interested in is that conferences like this are brilliant for seeing how we can actually interact and learn from our own colleagues rather than trying to reinvent the wheel every time. And, you know, though it pains me to say the cardiac surgeons do actually know something about the heart. How have you found it working with them to develop this?
It's awesome. I can only, I wouldn't have thought I would have used all of the prejudice that you can use and all the cliches, but no, definitely you can learn a lot, and you should really build bridges. Actually,
absolutely, that's brilliant. Jacob.
Thank you so much. Excellent lecture. Thank you so much. Microcirculation versus macrocirculation. How important are microcirculation from your perspective in the survival of our patients?
I think way more important than we currently know, because it's hard to get hold of it. I showed you the microcirculation camera, sublingual camera. Has anyone ever applied such a thing in their ICU or somewhere? Yeah, you know how hard and how cumbersome it is to use. So that just gives you a glimpse. And I mean, PET scans, you cannot do this in actual cardiac arrest patients, or it's really highly demanding. So it's hard to get hold of it, but I think it's way more important than we have found until now.
Yes, thank you for an excellent talk, and they are fascinating, these insights from these animal models. But is there anything in here that you apply in your clinical work that you think about, for example, just lowering saturation to avoid too much oxygen or stuff like that when you do resuscitation on humans?
Yeah, well, in the conventional CPR, we do everything like we always did. Like in the conventional ALS, without extracorporeal circulation, all is as in the guidelines. So they say titrate the oxygen, but for that you need to measure it, and you know how bad the clip works when someone is centralized, and all of these. Once we have extracorporeal circulation, we already have applied, so the working group has applied the results from the animal experience also in humans. So there was some studies already published, first in man. There is a case report of 120 minutes cardiac arrest successfully recovered, and we also use a newly developed device already in the eCPR and in the streets, which helps us to do all of these things, like keeping blood pressure high, pulsatile flow, oxygen titration, and all of these things.
Is there another question at the back? Did you have your hand up? Or? Well, thank you very, very much. I think it's absolutely brilliant. And again, I think this is a conversation that should carry on afterwards, because I think, you know, marrying up the science, the mitochondrial resuscitation with the microvascular resuscitation, and the macro of how we actually deliver this to our patients is how we're going to move forward and save more lives. Carrying on the theme of going deeper and deeper into the physiology and anatomy of what we do, our next speaker, Jacob, now I'm going to say the surname wrong, I think, Stensbell?
Yeah, very close.
Almost. So Jacob is an anaesthetic consultant specializing in trauma and bleeding, and has a big research interest in trauma. I remember hearing his fascinating talk a few years ago, talking about the endothelial reaction to blood transfusion. And again, this is something as we look at our patients, as we try to reperfuse them after trauma or after any sort of bleeding, and seeing how this all comes together. But I'll hand you over.
Thank you so much for the kind introduction. Thank you for having me back. I'm really honored to be back at the Big Sick. It's always a pleasure being here. I really enjoy the discussions, and let's just continue on that path. As mentioned, I'm an anesthetist doing trauma, but I'm also a transfusion medicine specialist working part-time in the blood bank. I've been doing that for more or less 20 years, trying to build bridges in between the clinical environment and the blood bank. One of the important parts is that I have no conflicts of interest at all, so I'm just working from the perspective of evidence, of course. Good or bad? Thomas, good or bad? Help me a little bit. How is it in Bergen? Is this good in Bergen? Yeah, exactly. And this is a solution, actually. It's quite simple. Thomas, good or bad? Yeah, what is this? What is this? We've been talking about the heart, microcirculation. We have been potentially, we need to talk about oxygenation. This is the lung of a COVID-19 patient
with severe damage to the lung. So this is necrosis, ischemia, and bleeding into the areas of the ischemia. This is an autopsy for the first phase of the pandemic, trying to understand what the problem was. Here you have the solution. Simple, right? So what we know now is that endotheliopathy is important in many types of patients. From trauma, we've been working on trying to understand why do patients actually develop coagulopathy. So now our understanding is that in patients accidental injured and at the same time bleeding, they are sometimes challenged by shock, and this shock induces some kind of coagulopathy. We entitle this acute traumatic coagulopathy, or as Karen Brohy from London actually in the beginning said, acute traumatic coagulopathy, or in shock and hemorrhage. So this is kind of pivotal part that you actually have different types of coagulopathy that develops, and our resuscitation can further affect this coagulopathy and the outcome of our patients. But actually, systemic endotheliopathy is probably one of the drivers of this. We have shown in some evidence that much of this coagulopathy from endogenous hyperinization to platelet dysfunction is actually driven by the shock, the catacombs, and the damage to the endothelia. So understanding the endothelia is extremely important. As the previous speaker said, microcirculation is important, and I believe it's really, really important. Of course, we need to focus on minimizing downtime in CPR, but as soon as we have some kind of control, microcirculation, in my mind, is probably the most important part. Not only having perfusion and oxygenation here, also having the ability to form a clot, but remembering again that out here on the sideways, you have the endothelia. The endothelia is extremely important. You have all the good things happening at the level of the endothelia. The endothelia is a solid organ. The glycocalyx on the surface has the purpose of avoiding activation of the circulating blood. So the surface of the endothelia, as seen here, is actually like a fresh caught fish, very slippery, very nice. And this actually has the function to avoid that clot are actually formed at the level of the endothelia. Remember, the endothelia, the microcirculation, is present in all cells in relation to those all organs. It's actually pivotal to understand that the endothelia is present in all veins, arteries, present in all organs, and you really need to understand that this is where life is, okay? Life, love, all the sexy things. Signaling, you have transport, you have diffusion, exchange of gases. So this is where it all happens. So we need to understand, is this important? We have looked into this for 10, 15 years, looking into the endothelia as seen on the left part of this figure here, the endothelia on a normal surface. You have the endothelial cells, you have the glycocalyx protecting the endothelia, and you have cells on the top of it. If you damage the endothelia, and in severe damage to endothelia, you actually shatter all the cells, the glycocalyx, and you get a leaking endothelia. So this is endothelial leakage syndrome that is actually developed in many types of critical illness. We have shown that it's actually the level of catacombs that actually, from a toxic point of view, damage the endothelial cells and sheds the glycocalyx. So again, having an injurious hit, that could be cardiac arrest, that could be sepsis, that could be trauma. If you have shock, you get to a high level of catacombs, and you will actually, by toxic pathogenesis, you will actually completely shed the surface, completely damage the endothelia, and we will cause this endothelial leakage syndrome, capillary leakage, that actually affects that you have edema at the level of the cells. Edema causes hypoxia, and you further damage the microcirculation. So this systemic endotheliopathy that we have entitled SHINE, or shock-induced endotheliopathy, is driven by shock, is driven by catacombs in our mind, and is really important to understanding how we can actually improve the prognosis of our patients. We have looked into different types of patients. We started in trauma, now we have looked into sepsis, cardiac arrest, myocardial infarction, and burns as well, and we see the same pathogenesis, that this SHINE, or this shock-induced endotheliopathy, is actually the same type of damage to the microcirculation, same type of damage to the endothelia, very unified from condition to condition. So the big question is, now we can identify this endotheliopathy, but can we do anything about it? What do you think? Can we do anything about endotheliopathy? Yeah, we can avoid it. How can we avoid it? Or could we actually even manage it or treat it? Yeah, we can, or we have really been trying hard. In trauma, hemorrhage, a lot of studies have been looking into whether plasma is good. And as you know now, the current standard of care in many countries is actually giving high dose of plasma. This is based on John Holcomb's study, the PROPER trial, showing us that in trauma hemorrhage with life-threatening or massive hemorrhage, if you have a patient arriving and you give a high dose of plasma and platelets as compared to a lower dose on plasma and platelets, you do see a shift in survival already within the first hour of treatment. And this is standard of care in many centers to try to improve the early survival in trauma hemorrhage patients. The group from John Holcomb also tried to understand what is actually the effect on biology here. And this was actually an animal model just to show us that you have rodents, hemorrhagic shock, and you resuscitate these animals with lactated ringers after hemorrhagic shock. You can actually see at the level of the glycocalyx, that's the surface of the endothelia, you will further shed and damage the endothelia. But if you actually resuscitate these animals with plasma, you can really gain some revival of the endothelial surface, as seen on the thickness here, but also as seen here, in patients receiving lactated ringers, rodents, you can see that there's no microcirculation. But if you look at microcirculation here in patients resuscitated with plasma, you actually gain some kind of rescue of the microcirculation in the endothelia. So again, this is kind of a proof of concept that you can actually do something about it. Potentially more important, the PAMPA trial, trauma hemorrhage again, showing us that in a randomized controlled trials of 500 patients in US, very sick patients, mean systolic at 68 at the scene of the accident. If you resuscitate these patients with 2 plasma as compared to ringers, you really get a survival benefit that is important. Survival is increased by 1/3. So we have worked together with the PAMPA group in order to understand what is going on, and we really believe that at the level of the endothelia, some of this happens. So we have been looking at these patients, and we can see that we have 2 groups here in the PAMPA trial, trauma hemorrhage receiving plasma or ringers. You can see one group, one cluster of patients is actually have a benefit from this intervention, plasma, as compared to placebo, lactate ringer, and one group do not. And one of the markers of this effect is actually syndicin 1, that is a damage marker of the endothelia. So again, showing us that the endothelia important for the effect of plasma in trauma hemorrhage is there. In many countries, for example, the mainland Europe, Switzerland, Austria, a lot of coagulation factor concentrates are used for trauma hemorrhage instead of plasma. This is kind of some of the controversies so far. And the US group has as well looked into whether these coagulation factor concentrates can actually repair part of the endotheliopathy. Again, looking at the endothelia permeability, again, if you have damage, you have permeability, you have leakage. So looking at these data, again, laboratory data, shows us that if you go to coagulation factor concentrate, you can actually repair part of the permeability, but going to the highest dosage of plasma, you can actually regain normal permeability. And why is that? Remember, 1/3 of your plasma in fluid phase is actually lying there in balance with the endothelia, not in the circulation, but actually lying in balance with the circulation at the level of the glycocalyx. So that's 1 out of 3 liters there. And if this plasma is sick, related to the condition, the shock, the endotheliopathy, if you substitute this, you can potentially rebalance part of this and rebalance and rescue the endothelia. So plasma is important in trauma hemorrhage. We have evidence to support that this is the way to go. Randomized evidence, laboratory evidence. We have shown that plasma can actually revive the endothelia. But there's also a difference in between different types of plasma products. And this is important for a blood banker to understand that we need to focus on what is in our toolbox. Plasma is not only plasma. So we looked into a group of patients, a new plasma product, comparing our standard plasma fresh frozen plasma, to octaplast, that is a pooled plasma that is pathogen activated, and it's microfiltrated 3 times. You have removed all the microparticles, all the immune complexes, and you have a standardized product. And we took that into a very famous bleeding model, that's thoracic aortic dissections. They bleed a lot when they go off pump, as you know. So a nice bleeding model to ensure that we had a relevant bleeding. And we took and compared in a randomized clinical trial these 2 types of blood products in order to see if there was a difference. We thought there would be a difference because octaplast is potentially a product that can save the endothelia faster and better. And this was what we saw, that we actually could revive the endothelia better at both 48 hours, 24 hours and 48 hours at the same time, going off pump, weaning, going into the face, and actually seeing that we could rescue the endothelia even better. So we could revive the surface, we could restore the seabed, we could restore parts of the circulation at the microcirculation level. But how did this actually affect these patients? Bleeding intraoperatively in the phase where the surgeons try to get control, you're weaning, you're transfusing these patients. Bleeding was less in the groups that actually, in the group that received the octaplast, the new product. Total amount of transfusions were reduced by 1/3, and the patients developed coagulopathy needing coagulation factor concentrates like fibrinogen or whatever were reduced to a half of it. Again, controlling endotheliopathy, controlling coagulopathy was kind of a downstream effect of controlling endotheliopathy. And we could see that there was also some beneficial effects on this small study, 40 patients only, but again, showing an effect that some kind of restoration of endotheliopathy could actually benefit our patient. So there's a difference between blood products, and you need to challenge your blood banker to understand what kind of products do you need for your patient with critical illness, or in particular bleeding. Another part is actually understanding that this is simple, but also understanding that in the fluid phase of the blood, there's a lot of factors, and you need to restore this balance. But you also need to restore the balance and the interaction at the level of the endothelia. So one thing is to restore the glycocalyx by using plasma and getting a rebalance here at the level, but also understanding what is going on at the level of the endothelial cells. Prostacyclin is part of the metabolism in endothelial cells. Now it gets a little bit nerdy. Yes, sorry, I can't see it. 10 minutes, yes. And at the level of the endothelial cells, you have this prostacyclin that is part of the metabolism of the survival of the endothelial cells. So our thought was that potentially this were actually related to this endothelial damage, that the prostacyclin is actually exhausted in its response. And by adding exogenous prostacyclin, we could restore the endothelial cells. So we went into a small study in the late phase of COVID-19 in Denmark, randomized 80 patients in a randomized control blinded trial, 80 patients going into the ICU needing mechanical ventilation. And we wanted to actually identify the patients most sick by endotheliopathy. So we actually saw some data from some colleagues in the UK that could tell us that the highest mortality in COVID-19 patients could be seen in patients with a soluble thrombomodulin marker above 4. So this actually helped us in finding the right patients with endotheliopathy, the patients with the highest mortality from COVID-19. So we did the trial, and actually we powered the trial in order to see the median days alive without mechanical ventilation at 28 days. And we could see that we could actually increase the number of days alive without mechanical intervention from 5 to 16 days in a small group of 80 patients. It was not significant, but it was a nice trend. We looked at other markers as well, mortality 22 in the prostacyclin group as compared to 44. Again, small study, not significant, but a nice trend. At 90 days, same trend, but again, lacking some power, and it was a small study of 80 patients. SOFA was significantly reduced, so we actually got some kind of control of endotheliopathy and the related organ injury in these patients. All the other markers of ICU survival were also affected some significant, but most kind of a trend. So again, of a positive signal, but not a positive trial in that way. But one of the things that we found that was really interesting here was actually to see the effect of prostacyclin in these groups. The survival curves, as you can see, there's a little bit of overlap. So this is 0.6 is the p-value. But have a look. Intervening patients arriving in the ICU with severe COVID-19 endotheliopathy. Very high mortality, around 50%. We could actually see the effect of giving 3 days of low-dose prostacyclin. We could see the effect after approximately 14 days. So we started something restoring the endothelia, restoring microcirculation. Very, very interesting. And I hope next year at the Big Sick, I can share these 2 trials that we have just concluded, a trial in trauma, and we have this trial in septic shock running currently in Denmark. But again, we are really looking forward to share some of these new endothelial rescue trials to see if we are actually on the right path working with this. Again, simple, but remember, endotheliopathy, the interaction with endothelia is pivotal to survival. The next generation of research is actually digging deeper, getting to a level where understanding how is actually these endothelial cells, how are they doing from a metabolic point of view? So you've heard about multi-omics, omics, proteomics, a lot of these analyses. So we're working together with the PAMPER group in the US, with the HEM study of plasma showing a benefit of survival. So we have been looking at a lot of markers to understand what is going on at the level on the endothelia. As you see, this is hierarchical analysis, very complex. But one of the important parts were that we found that in these patients with severe trauma, hemorrhage, receiving plasma, you could actually, at the pre-hospital point, you could see that there was actually 2 different levels of mechanism. Kind of a perfect storm where everything goes up and you need to control it. At the same point, you have some kind of consumption of all the factors in there, an exhausted response in these very, very sick patients. But we could see that we could partly control this storm by intervening with plasma to ensure that you could actually get an effect on survival by using plasma instead of ringers in these trauma hemorrhage patients. So part of the mechanism is to control the storm, to restore the massive consumption, and you could actually see there was 2 paths of these patients. A very interesting finding of this was that the most significant effect was in patients with trauma hemorrhage and traumatic brain injury in parallel. So patients with bleeding and traumatic brain injury, they have the most benefit from this plasma intervention. How can that be? Remember, endotheliopathy in the brain is the brain-blood barrier, and you have the endothelia at the level of the blood-brain barrier. If you have leakage at the level of the blood-brain barrier, you have a poor outcome. So restoring part of this could potentially be the effect of this. Again, important to understand that we are now looking into whether we can control this perfect storm. One thing is to avoid it, to stop it, but another thing is, can we control it? And this is what we look into now to try to understand how can we reduce the risk of endotheliopathy and a bad outcome of our patients. So currently, we know that in trauma hemorrhage and in sepsis, limit clear fluids. In a trauma hemorrhage, it is extremely important because this will induce further coagulopathy. Plasma is the way to go in trauma hemorrhage for sure. In sepsis, we don't know yet, but we are working on it. Prostacyclin can potentially restore the endothelia and kind of rescue endotheliopathy, and we see this as a potentially new agent in future treatment. Further trials are needed, both in COVID-19 but also in other aspects as well, and we are giving you 2 results in a couple of years. Digging deeper into understanding the endothelial cell is, for our point of view, very, very important. We need to know what is going on. Why are these patients divided up in typically 5 groups? Low survival, high survival, and how can we shift these groups in between? So going into these metabolic areas are very important to understand this from our point of view. Thank you so much.
Thank you so much. Any questions? Yeah. I will go to the Abernathy first.
Thank you. Excellent presentation.
Thank you.
In the initial resuscitation, have they looked at a comparison between resuscitating in trauma with whole blood versus components, packed cells, plasma, and how the endothelium responds to that?
This trial is ongoing. Jason Sperry and his colleagues from the PAMPA network, the LIGHTS network, I don't know if your HEMS service is part of that, but you have 8 HEMS services in the US that is actually driving these studies. And that is the LIGHTS network. They have done the PAMPA trial right now, and they have done the Tomahawk, and they are on the way with the whole blood versus components right now. Whole blood pre-hospitally, whole blood in the initial resuscitation in trauma. So this trial is ongoing and results are coming, and we hope to collaborate further with this group to understand where is the effect. So good point. Thank you.
Yes, thank you for a very interesting presentation. I have 2 questions regarding COVID-19 and sepsis. So the first question would be, besides prostacyclin, do you have like any summary what's the current picture of similarities and differences between like sepsis state and COVID-19 induced state in terms of endothelium and coagulopathy? And number 2, the question was if there is any data, if there some kind of like plasma resuscitation has been, you know, tried in trials, or if there is like evidence from population studies of plasma resuscitation in sepsis situations. Thank you.
Okay, the second question on sepsis resuscitation. We have done a small randomized control trial, and we are eagerly wanting to present you those results. And our US colleagues, Phil Spinella, has just closed a larger trial, and we're really looking forward to that. So plasma and sepsis, it's too early. We don't know that yet, but it's potentially very, very interesting. COVID-19, as compared to sepsis, is a state of hypoxia, shock, and damage to the tissue at the cellular level. So you have this endotheliopathy. Remember, COVID-19 is actually an infection at the endothelial level in the lungs. So it's actually endothelitis. So again, our really positive effect, even though the study was not significant, only a trend, again, remember that COVID-19 is actually a disease at the level of endothelia, not only the lungs, but also at the systemic levels. So again, rescuing the alveoli, rescuing the pulmonary endothelial cells by restoring the function, restoring the oxygenation and so on, is really, really interesting, but potentially the same mechanism in sepsis. You just need to find the level that is prognostic, detect that in some kind of a fast assay, and this is what we have developed, and then you need to intervene in the right patients. This is pivotal here, that we found the group of patients with the highest mortality, the highest level of endotheliopathy or with hereditary, and we intervened in those, and that's why we saw this positive signal. Great questions.
Thank you. Last question.
Thanks. Do you think plasma's got a role in treatment of isolated traumatic brain injuries? So in the absence of hemorrhage, for example?
Yes. But we need to study. Yeah. And I know the PAMPA colleagues are really working on that. It's really interesting to see how you can actually rescue the TBI patients. And of course, one thing is TBI and bleeding. And this is where we see the signal in our collaboration. But again, in patients with severe TBI, going into a treatment with the neuroprotective, so intubation, ensuring perfusion, all the good things. Potentially here you have plasma as a part of initial treatment, but we have to study. We have to do it in a randomized controlled trial prior to implementing in it clinical practice.
Thank you so much. This whole morning, for me, has just been brilliant. Just so many insights that I think will change my practice tomorrow and in the years to come. Now, I've got a couple of quick notices to give you, and say we're going to cut the break short a little bit, just so that we can all get out onto the slopes when we want to. But Quick reminder, if you haven't signed up to the new fondue list, then please do so. It is outside. There is something about cows exploding full of cheese on the mountains. We just want to avoid that. And then if you have a few minutes to spare at 12 o'clock, I would highly recommend joining the Central Line workshop. They'll be quick. They'll still get you out onto the slopes, but you'll take some valuable skills with you, hopefully not for skiing, but for your future practice. And then after the break, if we try to come back for 10 o'clock, we'll have a short presentation from Corpulse, and then you need to bring your extrovert in you, because we're going to do some case discussions and we need you guys to interact and help us to work out these cases. Okay, so thanks very much. Unless, Ollie, did you have anything else to say? Nope. Cool. Enjoy your break. We'll see you at 10.
911, where is your emergency?
Hi, we got a hot air balloon accident.
No, that should be. Give me 2 minutes. Just wait. It's gonna be a surprise. All right, ladies and gentlemen, it's 10 o'clock. Please take your seat. Thomas, can you take all the people outside inside? Thomas, bring him inside. All right, so last night we advertised his TPS running group, the Mountain Goats, and when was show up time? 6 o'clock, right? How many showed up? What do you think? 11. Ooh, okay, that's a good guess. All right, so 11 showed up. And we went a little bit above Zermatt towards Matterhorn. And we're about 90 people with the guests and speakers. And because 11 showed up, we have to make it up for U79. 79 of flutter kicks, push-ups, Smurf jacks, 8 counts, and burpees and all that. And then we visited a church which was built in the 1600s. And we lighted up 79 candles. I'm kidding. It was our 11 candles. I hope the church didn't burn down. And then we ran back, and while we were all sweating down there, I gave them a 10-minute speech about Matterhorn while they were freezing. And please come up here, I have a small present for you, for the runners. Come on up here. And a big applause. Come on, all the runners up here. I'm serious. Sandra? No? All right. I guess they went back to bed. But anyways, so this Toblerone for the as a trophy, and the Toblerone, if you haven't noticed, it's shaped after the Matterhorn. Okay. Thanks so much. Relations.
Now all the gains are going away.
All right, so there will be something else tomorrow at 6 o'clock. Whoever's interested, meet us at 6 o'clock tomorrow morning. So now it's okay. Now it's a small sponsor talk from Corpals, and just before you start, okay, there it is. I just wanted to say we've been using Corpals. There's the mat in our helicopters, and we are super satisfied with them. There's several reasons for it. First of all, it never failed on us. Second of all, they also work at minus 25 degrees in the snow. And it's amazing how much impact they also withhold with us, keep dropping them into crevasses. I'm just kidding. But we were impressed and we were very happy. So thank you for making such a great product.
Yeah, thank you. Is that working? Okay, cool. Thank you, Oliver. That was very unexpected. And I also wanted to start the speech with a big thank you to the organizers here. I think it's a massive undertaking at the moment to have an in-person event. From our perspective, we've signed up for like maybe 25, 30 events this year, and there's some that are starting next week, the week after, and a few weeks ago we got the cancellation. It's like, oh, we're going digital, we're going hybrid, oh no, we're going digital. And I was just saying to them, it's so fantastic to be somewhere where you don't hear every 5 minutes, hey Bob, you're on mute. This is just fantastic to be here, to see people's reactions, to have you guys touch things, and have the opportunity to really be part of it and not just be somewhere and you don't really know whether you're talking to somebody who's unstacking the dishwasher or probably doing something else in the meantime. Last night, Oliver and I were talking, and I said, like, do I do a presentation? He said, like, yeah, can you do a cardiac talk? And I said, like, okay, then let's do a cardiac talk. The last couple of years, I usually presented stuff from our animal lab or so to keep it a bit more scientific. And I'm trying to put something together, or I tried to put something together this morning that is a bit more cardiac, but I think you can't do Zermatt without using mountains. And I sort of want to start with a bit of a question. Who in the room knows what we are looking at? Who thinks he or she knows what this is? We've heard jokes yesterday about surgeons and medical things, so it's also fine if you think you see a skiing resort or a mountain. But what you're actually looking at, I guess all the guys that wear the red jerseys know exactly what this is. This is actually the Matterhorn. It's the Matterhorn from the Italian side. When you take the lift or the helicopter up and you ski down towards Cervinia, this is how the Matterhorn looks like, because we all know it like this. And that's a little bit where I want to see, or I want to show the similarities with ECG. So on one side here, we have the mountain as we know it. We have the mountain as it was the probably influential to the Toblerone chocolate that Oliver just presented. So what we know, and on the other side, we see an ECG as we know it. So I guess everybody here in the room has seen this numerous times. Standard 12 lead, printed differently, sometimes on a larger piece of paper, sometimes smaller, with a little bit of extras here and there, but this has been the standard. And that's for a good reason. So 12 lead ECG, we sometimes like talk about gold standards, definitely there, was introduced about 20 years ago, extremely well accepted and massively evidence-based. Actually, we base a lot of SOPs on what we see in the 12 lead. There is hundreds, if not thousands, of pages of guidelines written around what you see in a 12 lead ECG. So that's today, and that's good. But over the last 5 to 10 years at conferences like this or different ones, people come to me and say like, oh, can I use the leads that I have? Can I put them differently? What if I want to get extra leads? If I want to get a V7, V8, or V9, can I use them? What do I do? Then you start explaining them. Oh yeah, you can do this, and you just use them and replace like 4, 5, and 6, and then print out and take your pen and erase that. And we thought like, okay, there must be more. So we were looking what was out there with the goal to just achieve the next step with ECG. And what you see here is, of course, the 12 lead I think will never go away. But what we heard was like the next interesting thing was the right chest lead. So V3R, 4R, 5R, and 6R, as well as the posterior leads V7, V8, and V9. And then when you start looking, you look what else there is. So you find, okay, there's orthogonal leads. There's something called vector loops, which I had to learn as well, but I did bring a few slides so you can see what they actually look like. And then there was always something in the background like, what if we make this too complex? Is there probably also a possibility how we can display ECG readings or measurements at this point so that it's a little bit easier to interpret? So again, as the mountain, if we look at a heart muscle, and I don't have nice pictures like we saw of the larynx folded up, but it looks different from whichever angle we look at, whether we go around it or in this case just rotate the heart muscle. So what we came up with is something like that we summarize as a 22 lead, and if you see at the roll up here or at our booth, you see the 22 leads everywhere. So, but what we didn't want to change, because from probably my experience, and I think it's also a little bit the feedback, we don't want to make it more complex. People need to be able to perform the skill of obtaining a diagnostic ECG, and therefore we wanted to stick with the same 10 electrodes. So we didn't want to introduce different electrodes or different placement, because that will just confuse people. So the same 10 electrodes that you use for your extremities and for your chest leads, but that through an algorithm gives you 22 leads. So you get your posterior leads V7, V8, and V9, you get the right chest leads, and all without any additional time. So that was a little bit the goal by this. So what the device does, it takes that ECG, takes the raw data, sends that to a server. That is actually quite a powerful algorithm, and then it takes a quarter of a second, and it comes up with all this information and sends it back to the device. And whilst I'm sure, like you can see it here, right chest leads or so, they don't look too dissimilar to what we know from the standard 12 lead. I thought it could be interesting for those who, like me, didn't really know what vector loops were. I've been told that cardiologists grew up with this, but to me that was actually new. So it is basically that red rotation that you have in the X, Y, and Z angle of the torso here. And for example, if they're healthy, it's always good if they go in a nice smooth rotation. So that means the conduction system is all good, and just as the opposite, if something like this shows up on a vector loop, there's definitely a conduction problem. I also mentioned that whilst making technology more and more sophisticated, it sometimes can become a little bit difficult. And in this room, I'm quite sure that everybody can interpret a 22-lead ECG, or even if we offered more technology, that it wouldn't be a problem. But devices are used around the world, and sometimes it has to be a little bit quicker and probably with less education. So we found a technology that's called a cardiac electrical biomarker. It's based on the polarity of heart muscle cells, and you can sort of see it as a electromedical troponin test. So it uses the polarity of the heart muscle cells, measures it, and basically gives you like an indicator whether the heart muscle is in a healthy condition, whether it's a little bit questionable, or whether there is something wrong that may or may not be of ischemia. So this is a little bit based on the troponin numbers as well, so people don't really, or not too surprised. And on the other hand, to keep things a little bit manageable, this is of course not only something that we wanted to introduce to have it on the for the ambulance, for the helicopter, or where the device is. Modern devices do have connectivity, so this here has like 4G and Wi-Fi and everything. So of course you can use this data that you have gathered, different printouts between 5 and 10 pages. You can send that through the built-in connectivity to a server, so that you can work together with specialists, most likely in this case cardiologists or emergency physicians, depending of course of the country and whether something like this exists. That of course connects to the Corpus Mission Live server, but we work in a very traditional field, so you don't necessarily have to have servers and tablets and be all connected. This is really the common use, and I heard Damagoy laugh here. So yeah, this is really there. This is not a typo. So I don't know whom of you did send a fax privately in the last 2 or 3 years. I most likely haven't. I think we don't own a fax machine. I would probably have to scan it and go on a server or something. But hospitals, it's still very common that they do want to receive ECGs, diagnostic ECGs, to prepare for PCI via that modern communication standard called fax. So fax or mail for the device doesn't really matter, and then you can send all that data ahead. Of course, you all will all be interested in the science behind this. Whilst an algorithm sounds like it's a little bit futuristic and so on, it's of course a evidence-based technology. I just copied a few things here. Some of the research, or most of the articles, actually come from the university in Basel. For those of you who want to have a bit of a closer read, we put together a sort of journal which we call Corpal Science. I did bring a couple of copies of that which summarize or have all these peer-reviewed articles in it, including also some that may be a little bit more fun to read. So they're all back at the booth if you would to like and have a look. The cool thing is this technology works with every Corpal 3, so I don't think that the Zermatt guys have it yet. That would be something that we'll have to look for tomorrow. But you can basically upgrade every Corpal 3, whether it's a classic or a touch, as long as it has some sort of connectivity, because it has to send that ECG to a server for that algorithm to work there. And therefore, I would like to invite you, and I made a bit of an in-person Congress mistake. I did not bring a single business card. I also don't really know where they are at the moment, but probably have to find them again. So if you would be interested, and I'm very sorry that I didn't bring any cards, please feel free to either send me an email, call me, or I had a very good idea yesterday, or like one of the participants here had the idea and said like, can I just find you on LinkedIn? If you want to find me on LinkedIn, please, if you like, also of course follow the Corpal's World LinkedIn as well. But if you email them about cardiac electrical biomarkers and 22 Lead Ecg, they're the social media team, so they will then start hunting somebody who can answer your questions. So you can also find me on LinkedIn and message me if you have either any questions or would like to try this, because it is server-based, cloud-based. You can have free trial licenses for this and just see how it would work in your system. Thank you very much.
Right. So now for our next bit of fun, we have got some case-based discussions for you. So first up, we had a discussion. So you've got myself, Mike Abernathy, and Will Smith to do some cases from our own experience to discuss with you and see your thoughts. The decision was made to split the Americans, so I don't know which one's going to be North America and which one's going to be South America. But what we need is your interaction. So there will be a roving mic, and we just put your hand up and just say what you think, because the joy of this is getting the richness of everybody's practice and different things and seeing things from another perspective. But I'll hand you over to Will.
All right, great, thanks. So welcome everybody. I'm supposed to stand in the square here so I can say hi to everybody that's out there in the virtual world or wasn't able to make it in person. So it's wonderful to be here. Thanks for the invite. And so we're going to talk about a couple of cases from the Tetons. So that's in North America, in Wyoming, and just south of Yellowstone. So got a couple cases. One's going to be a balloon mass casualty incident, so 3 hot air balloons. Another one's going to be an arm amputation, and then just a quick video that I put together of what we do for short haul for technical rescue underneath the helicopter when we don't have hoist. So no conflicts, no other financial disclosures to make at this time. So that's our big pointy rock there in the Jackson. That's the Grand Teton, and we do a quite active helicopter rescue program. It's all based off volunteers and just a couple of paid administrators to help with the program. So the first case is a balloon mass casualty incident. This is the recording of the actual 911 or the emergency call placed. And as you can hear, the dispatchers are just amazing what they're able to do, which call they should take information from, which call they need to just hop off and get to the next call. Because once you start having one of these big events, everybody pulls out their cell phone from their pocket and dials 911 for us. And so they've got a massive influx of calls. There's 2 dispatchers in the center at generally one time, sometimes 3. But again, just think about what a great job they're able to do, then to get us out there responding to the event, and then the next level of coordinating, orchestrating everything.
911, where is your emergency?
Hi, we got a hot air balloon accident.
Okay, where?
Jackson Hole. We just
Where
crashed a hot air balloon.
Okay, where are you?
We're
Jackson Hole. That's
just south of the Teton Village, in a field, something called Propane Road, something like that.
Okay.
We got all sorts of people spilled all over.
Okay.
We need fucking ambulances and all sorts of stuff.
Okay, what side of the road you on? I just need to get this information so I can get you in.
We're on the west side of the road,
Down
What color is the
by
balloon?
the Village Road. Down on the
Down now, yellow, red,
The
blue,
hot air
all
balloon.
sorts of
Are you
colors.
involved? Okay. How many injuries?
I'm sorry?
Are you involved?
I don't know, a dozen?
I'm not
Okay.
involved.
Okay. I'm going to let you know if I help on the way. All right. Bye-bye.
Yeah, ASAP.
Yep.
Okay.
Dispatch, stand by for a patient on fire mass for mass casualty incident in Teton Village, a hot air balloon accident.
Yes, we are aware. Okay, we're getting you ambulances, okay? Watch for the ambulance. Bye. 911, where is your emergency?
Hi, yeah, we just crashed in a hot air balloon.
Okay, how many injuries are there?
I don't know. We have 14 people. I think my wife's arm might be broken.
Okay. Do you know
I'm
how
not
many
sure
more
about the other
injuries?
people. Well, 13 people laying on the ground. There's 3, 4, 5 maybe.
Okay. All right, we're getting you ambulances, okay? All right.
Do you have a tracker on my phone?
I do.
We're out in the
I'm-
field south
yep,
of Teton Village.
South of
The
Teton
following
Village
units
in the
respond to a
yeah,
mass
I'm gonna get
casualty
you some
incident,
lat
hot air
while I'm
balloon
talking to you.
crash,
You can give me
possibly
kind of the status
14
of people
patients
there.
in a field
Okay.
just south
Yep,
of Teton
I'll
Village.
look around.
Medic 60, Medic 10, Medic 20,
Okay. I
Medic
think my wife
70,
has a
Medic
broken
30,
arm.
Engine
How are
61,
you?
Teton Village 51,
Okay.
Rescue 24,
Okay, left
Support
back on
19,
another person.
the NCIC
There's a
trailer,
back on another person?
and duty officer. End of
Okay,
page
left
814.
shoulder on
All right, so mass casualty incidents, where do you start? And so again, this is something that I think we all have interfaced at different types, different incidents. The first thing as I start looking through this is scene safety. And so whether or not it's a mass casualty event, it sounds like in the US we have more active violence or mass violence events, active shooters. So those definitely have much more of a scene safety type component, but so do we have the same thing in the wilderness setting. So whether or not it's an avalanche, whether or not it's a kind of balloon crash, looking at location and accessing to get to these patients, looking how many number of patients. You could hear the dispatcher trying to get how many patients do we actually have, and that ended up being something that evolved as we started responding to this. Initially we just thought we had one balloon crash, but then by the time that we finished there was actually 3 hot air balloons involved. Looking at command and control, so ICS or the Incident Command System, it's really how we organize and start building a response, and so it's very adaptable. Looking at your span of control, looking at how many kind of units or types of people that you can efficiently organize, and generally that's in 3 to 7. If you're trying to organize more than 3 to 7 people underneath you, then you need to kind of build out your organizational chart. Looking at then the mantra that we talk about for MCI, so the triage, treatment, and transport, and again that's the big basis of mass casualties and triage that we try and use. And then containment and patient tracking. So kind of how many patients you have, making sure that the green or the walking wounded aren't leaving the scene. And with this scene, we didn't even know how many patients we had. And a lot of the patients were the walking wounded. They walked back to their cars from where they parked because it was close enough where the balloon accident happened. And so again, trying to contain all those. So again, looking at scene safety, way we assessed this was breaking it into divisions, and so kind of division 1 was the northmost balloon, division 2 was the middle balloon, and division 3 was the south balloon. That's where the most significant injuries were. And then again, command and control activated a medical group supervisor to really start kind of organizing the patients, the care that needed to be done, communication with the hospital. And so as you can see here, this is the northmost balloon, the division 1. This is Division 2, and then this is Division 3 down here. And you can see there's actually quite a bit of distance separating those. So as we had our initial responders coming here, we didn't even know about this balloon down here initially, and that's where the more critical and the more serious injuries actually were. So I mentioned scene safety and hazmat, and so again, these are all huge propane tanks that are on the balloons, and that's what fires the big like turbo cannons, the big flamethrowers that actually heat the balloon to take it up in the air. And so again, worrying about these potentially exploding. Are they damaged with the crash? All these things to think about. We were lucky that the balloon chasers, so the ground crew that go around and help the pilots when the balloons come down, they were all on scene, and they had actually managed all these incidents or all these concerns before we even got there, got the propane turned off, and so that was a great help. Just some more pictures from the scene, again, breaking into that triage, treatment, and transport, figuring out how many patients we have, how injured are they, kind of where we need to go to contain them, what need to be transported off the scene first. And then this is the air ambulance helicopter that came in and transported the most critical patient that was right here. This is, again, that southmost balloon, or the Division 3 incident. And again, just multiple patients out here scattered around. One of the things we're starting to incorporate in our systems are drones or UAVs. How many people are using these in their system to some capacity? All right, a few hands up in the room. A great resource. Again, kind of just like any tool, you need to know how to use it, kind of how to deconflict it with other manned aircraft. That's one of the big things to be concerned about when you're using with this. This is the small DJI Mavic Enterprise Dual, so it's got FLIR or infrared capability, and so again, just great tool. Folds up into this little box, so you can basically just pull it out. You can hike into some backcountry remote locations, but definitely has limitations with about 30-minute battery life, and then generally kind of working through the FAA or the kind of Federal Aviation Administration with the rules of how far it can go and deconflicting with other airspace. And then we already talked about this a few times, and we've all been living this the last couple of years, but this was right in the middle of COVID as well. So again, trying to think about all those PPEs when you're dealing with a mass casualty incident, how that's all going to fit together. So here's the UAV footage. So this was just a little bit after the incident had been stabilized, but again, just gave the incident commander a better view of where all the balloons were located. For the investigation, they're able to get exact latitude and longitudes. And so again, just you can see here as the balloons hit the ground, they basically were drugged. And then like this one stopped as it got into one of the ditches. And so it was a big weather event. So kind of nice blue sky, few clouds. But then all of a sudden the clouds started building and there was a big kind of wind burst and basically dropped all the balloons rapidly and then drug them across the field, drug them through fences. And actually one of the balloons, the pilot actually got bounced out. So has anybody ridden in a hot air balloon? Kind of. So they've got like sometimes 15, 20 people in the basket underneath it. And so it's always kind of that balance of kind of the lift from the balloon and how many people are on the basket. And so when I went one time, basically said, as soon as you touch down, don't get out until we tell you, because if you lose one person from that basket, the balloon's going to go all the way back up into the air. And so on one of the balloons, it hit the ground hard, and the pilot was actually ejected out of the balloon. So as soon as he got ejected out, the balloon started raising again, so he's yelling to all the people in the balloon to pull the red cord, pull the red cord. And so luckily they were able to get it back down. It didn't go too far. So again, just trying to imagine the situational awareness. So where all those balloons are actually located, where are all your patients at. And so again, the incident commander can look at this imagery and be able to say, okay, we need some resources here, we need some resources there. And then right over here behind this group of trees that you can't even see from the other two balloon sites was very difficult to kind of put together until we started getting some of this imagery in. So being able to track the number of patients, we're able to get the client manifest from the balloon company, and this is really what helped us start to pin together the picture of how many patients we had. So 3 hot air balloons, 38 guests and 3 pilots, so potentially had 41 patients from the event. Luckily, we just had 1 red, 4 yellow, and then an unknown number of green, and luckily no black or kind of deceased patients.
St. John's, be advised this was a balloon accident involving 3 balloons, as you probably copied. At this time, we have got 1 red being transported by helicopter to Zermatt, 4 yellows, and undetermined number of greens. We're in the process of trying to sort out the greens. Copy.
So again, very important to notify the hospital of patients that we're going to be having and expecting. So that was the initial report. Here was the actual report. So 1 red, the patient here with head injuries near ear avulsion. Basically, the ear was ripped off, as well as multiple other chest and thoracic injuries, but ultimately survived and did well. 6 yellow patients, 4 green patients, no black or gray. Gray is an expectant category that we sometimes use. So again, and just like anything in the United States, multiple lawsuits are now pending because that little waiver that you signed before you get into the hot air balloon to say anything can happen, we're not responsible, again, they still try and go through the legal system. The rest of the patients transported to the hospital. The most significant injuries were the trauma A patient, and again, like was mentioned yesterday on the WHO education to try and improve mass casualty response, not just from the pre-hospital, but from the hospital. We've got trauma packets that are basically pre-designated, so trauma patient A, so they just start getting handed out, so you track the patients through the system. Trauma A was a 40-year-old female with bilateral shoulder injuries, sent to the OR for fractures and ended up being COVID positive. Again, kind of that whole thing. Now you're having to backtrack, okay, who was in the ambulance with that patient? Were they exposed? Now are they needing to be quarantined as well? And so working through all that. Trauma B was a 70-year-old female with chest pain admitted to the PCU or patient care unit. And then trauma C was a yellow patient, 70-year-old male with an open ankle fracture. And then the rest of the patients, most of them were evaluated and sent home. So the x-ray there on the left, that open ankle fracture dislocation, went to the operating room. This was one of the patients that ended up having bilateral shoulder humeral neck fractures. And so that's the other patient that went to the operating room. So questions, discussions, other thoughts that the audience has about this case that I'd like to bring up?
Yeah, just one comment. Boy, dispatch in these MASH casualty situations, just listening to the voice and the way she carried, that's one cool character because, again, she's getting multiple calls. You don't know whether you have 5 victims, and then you get the repeat calls. Yep. So is there just one balloon that everyone's calling in on, or 3? And yeah, just that brief snippet, she really did a great job in sorting things out, and it just keeps the whole tone down when you have someone like that.
Yeah, absolutely. I think the dispatches are the forgotten link a lot of times in that pre-hospital and kind of the hospital realm, but they're really where that care starts. The pre-arrival instructions, the EMD or emergency medical dispatch, and again, all this information. Yeah, we've got some amazing dispatchers. Any other comments or thoughts or questions on this case?
Sorry, maybe I missed it. At what point do you get the drone out there? So who flies it, and when is it on the scene?
Yeah, so right now we've got about 3 drone pilots, myself as one of them. So once we got the initial patient stabilizations done, that's when I went and flew the drone. So again, deconflicting that airspace initially with a manned HEMS ship coming in. So yeah, those are all things that we definitely have to look at. We're growing the program, getting more pilots, and again, trying to figure out when is the best time, again, to use that tool to get that better situational awareness. Great question, and it's something that we're still working through. Any other comments on the people that are using drones or UAVs in their systems?
At one point, did you find that there were 3 balloons versus 1 in the initial report, and wouldn't it make sense to fly the drone earlier on to try to see if there are any more casualties?
Yeah, the initial reports, as we were being dispatched, we thought we were responding to 1 balloon crash. Once we started getting people on scene, we started interfacing with the ground crews that were working with the balloon company, and they did a great job as well, giving us that additional situational awareness that there were actually 3 balloons involved. They knew a little bit better where the locations were because they're basically chasing the balloons as they're going, and so they're kind of waiting for them to come down and kind of help out. And so they gave us most of that information before we were able to get the drone up. But again, it's a big question, especially in a dynamic situation that's constantly evolving. When is the best time to put it up? Looks like, was there a question over here as well?
Hello.
Oh, one right there.
I have
Yes.
a question on the physician EMS staff ratio. So you're basically the mass casualty incident, the only physician on scene, or?
Yeah, so in the U.S. we don't have as much physician response in most categories. Myself being one of the medical directors for our agency, I've got a response vehicle. This is actually my MD1 Suburban, and so I've got all my kind of additional medical kit in there. So I've got capability to really do ICU level care for about 1 patient, so rapid sequence intubation and those things. But most of the response is by all the paramedics on the ambulance. There ended up being one of the other emergency department physicians that got on scene on this incident, and so it's really variable. But in most of our cases, we do not have a physician on scene.
Just around, a lot of patients seem to get discharged. So do you have any forward decision making to not convey patients and discharge them on scene?
Just clarify what.
So sort of advanced clinicians assessing these patients and then saying you don't need to go to hospital, not to overwhelm the system.
Yeah, so advanced triage into the system. There was multiple green patients that weren't evaluated or that were evaluated on scene and then basically released. The patients, the yellow category patients, the one with the injuries and fractures, they were all the ones transported. So yeah, there was some additional decision making initially.
So I'm just a comment on the drone usage.
Yes.
In Stockholm, for example, or in Sweden, generally the police operates the drones in their system. So we do have a collaboration with them. Is there anything you, and generally, do you get like police involved on scene in such kind of accidents?
Yeah, you can see right here is the sheriff's deputy, and so the UAV program that we have is actually combined between our Jackson Hole Fire EMS, which is the ambulance service, as well as Teton County Search and Rescue, as well as the sheriff's office. So we have a combined agency. We're all kind of interfacing with each other and using that more. The law enforcement definitely involved with the investigation, what actually happened, and so yeah, we collaborate very closely. So I'll be around if there's more comments, discussion later, but I'll go ahead and move on to the next case here. And so again, another kind of unique case where there actually was physician response by myself onto the scene, as well as one of my other partners, Dr. Wheeler. I think there was a couple people in the room that said they know him as well. But again, we're co-medical directors for really all the response agencies in the Valley. So our Jackson Hole Fire EMS, Grand Teton National Park, Search and Rescue, as well as our Forest Service. And so that's been a great linkage to basically have all the other different agencies responding, all have the same protocols, same medical directors, and so it really integrates the response capability that we have. So this was a traumatic arm amputation, and so again, looking at the scene, definitely a lot of blood, massive hemorrhage. What this is a drill rig, so it's drilling into the side of a bank where they're building a road to help stabilize it so you don't get a rock slide or a landslide. And his coat got caught up onto this auger as this was turning here and amputated his arm. So again, some of the dispatcher, the 911 tape recordings.
Alan is Jackson, stand by for a page on Fire Mass. For Medic 10 and Station 3 first responders, responding to the area of the Hoback Market, reference unknown problem. The following units respond to the Hoback Market. Reference a subject with an arm amputation. Medic 10 and Rescue 34 respond to the Hoback Market. Reference an accident with machinery. End of page 831.
So again, we start getting some
Jackson, Medic 10 responding.
Medic 10 copy. We're still getting we're having trouble getting the exact location. This might be just a little north of Hoback Market. This was an accident with some kind of drill and control. RP states the patient's arm is amputated, serious bleeding.
So the other concern was the patient may still be trapped into the drilling apparatus, and so again, start working with some of this big heavy equipment. Your typical auto extrication equipment for just regular car crashes sometimes isn't enough once you start doing some of this heavy machinery extrication. So again, that was something else that we're trying to get on scene and activated to get down there and help. As I started responding.
Jackson, MD1.
MD1, go ahead.
When you're requesting your IDO, can you request that they bring blood products?
MD1, can you repeat that?
Yeah, in your request for Air Idaho, can you request they bring blood products?
Okay.
So we don't carry blood products on our ambulance currently. There's definitely more and more agencies across the United States, still just a handful, just with the recognition of how important blood products are in that initial resuscitation. Like we heard earlier this morning, again, the crystalloid resuscitation just doesn't do the kind of the person very much good. So again, the blood products are an important link in that chain of survival for this patient. Just hearing the initial reports, massive bleeding, arm amputation, calling in an air ambulance or a helicopter EMS, they're generally where we're get blood products to the scene, and that's what they brought. So they had 2 units of packed red blood cells and a unit of FFP, and so that's really kind of what helped save the patient's life to get him to that next stage in that chain of survival. So incident command, I mentioned that earlier, and I think that's really important anytime you're responding and working through these significant events. The more that you have people in charge, you know who's you're reporting to, who's reporting to you, the chain of responsibility, and so that, again, very important, and this is the initial report.
Jackson, Battalion 5.
Go ahead.
I am on scene. We have a patient caught in a drilling piece of equipment off the highway on the west bank of the road. You will need to come off the highway to access. It appears the best access is going to be from the south. Rescue 34 has arrived on scene. Break.
So again, just setting the stage. Where does everybody need to go? And so again, that's really important, especially as you get multiple agents starting to respond onto the scene and then be able to coordinate the care. So again, this is what the scene looked like. This is the drilling rig here with the big auger. And again, you can see probably arterial type bleeding just by the nature of the blood pattern. And so the patient actually got spun around this like a rag doll multiple times before they were able to get the drilling off. So not just the traumatic arm amputation, but also the potential massive multi-system trauma that could be going on. Here's the recording from the dispatcher. Again, just amazing job.
911, what's the location of the emergency?
I'm in an ambulance, stat, fucking, Hoback Junction, the project, this guy's arm got ripped off, holy fuck, he's bleeding to death.
Okay, where specifically do you need the ambulance? I need the address.
There's a Hoback Market, fuck!
Are you at the Hoback Market?
So yeah, really getting the important.
We are sending an ambulance. Are you at Hoback Market right now?
It's a job site right in front. Damn, go get help!
Okay.
I don't know what to do. What do I do? His arm's ripped off his fucking arm. His arm is ripped off.
Okay. I understand, okay? We're sending an ambulance to Hoback Market.
Everywhere. Should I pick him up?
All right, so again, quite high level, but again, the dispatchers have to tease out the information. Where is the patient located at? Pretty obvious what the condition is as you start going through some of the other pre-arrival instructions and the EMD or the emergency medical dispatch. There's not a card for this. And so there's lots of cards for straight cardiac arrest, for other anaphylaxis, different types of things, but there's not a specific card for arm amputation. So they did amazing getting the resources there that we need to save the patient. So this is, when I got on scene, they had the patient in the back of the ambulance already. Here was basically the hole of where the arm was disarticulated. This is actually the scapula as well, and actually a dislocation as well as a forearm fracture. And so again, the arm was just completely separated from the body. And so looking at the ability to put on an extremity tourniquet, again, the junctional hemorrhages are the big problems that we've had with the kind of Iraq and Afghanistan conflicts. We're really good at the extremity hemorrhage with kind of tourniquets, but the junctional area, so the axilla, the neck, the groin, still really difficult to get bleeding control. So what I did was I just took, again, just a massive hole, just started taking whole rows of Curlex and just start packing. The bleeding had stopped, so he was having some of his permissive hypotension, and his mental status was unresponsive, and he was having some agonal respirations. And so as we got the bleeding controlled, kind of the March algorithm, so the massive hemorrhage control, and then you start working through airway, respiration, circulation. And so got that packed, and then we went on and did rapid sequence intubation. So the patient still had enough gag reflex, but we wanted to get control of the airway, and so we could kind of keep working through the massive resuscitation. So again, just the anatomy of what we're dealing with. So, I mean, we've got major blood vessels, but then all the other blood vessels that feed the latissimus and the other kind of muscular structures are all big bleeders as well. The pectoralis major was basically ripped off and fractured the sternum as it was ripped, so just massive amount of injuries. So point of care ultrasound, that's one of the things that we're kind of also introducing in our system as kind of more a physician level, but trying to get that down to the paramedic level. Had one of the butterfly devices with me on scene, and so again, just gives you that a little bit additional decision making. Looking at heart, the heart had still good cardiac activity, was matching the tachycardia with a rate about 130, 140 on the monitor, but we did not have a palpable pulse. And so, as you can see, we started optimizing circulation. So again, this kind of gets into that little bit of a fringe treatment area. It's like, what do you do? But again, no pulse, but we knew there was cardiac activity. So again, just trying to optimize that perfusion. Used it to also help with line placements. We did place bilateral intraosseous, had a lot of difficulty getting any access, so we were working on kind of venous access in the femoral area, ultimately missed vein but got artery, and so we actually with the flight crew transduced the arterial pressure, and so we saw we were getting pressure still about 10 to 20 millimeters of mercury, and so again, interesting to kind of get that additional help in our decision making. And then we did an extended fast exam, so no kind of tension pneumothorax that we needed to immediately kind of work on. So again, helps you prioritize what your life-saving interventions are and what order you should be doing them. Talks about this a little bit more. Again, this trauma-induced coagulopathy, we're learning more and more about this, but again, the more blood that you can stay safe in the body and not replace, the less of this you're going to have. They really talked about the lethal triad, but really moving on to the lethal diamond, really more important and focusing on the calcium with the hypothermia, the coagulopathy, and the acidosis, especially once you start giving blood products. So once we started giving blood products, we also started giving empiric calcium as well. So transport decision and destination. And so again, once you start getting helicopters in the mix, then sometimes that closest facility may be hopping over our local facility and going straight to a regional trauma center. In this case, the patient needed more blood. And so it was an 8-minute flight to our local level 3 hospital, and we called ahead. They had our massive transfusion program kind of ready to fly to the level 2 trauma center. Would have been a 40-minute flight, but we've already given all the blood products. We've barely got a pulse back now at this point, so we decided to fly to the closest facility that had blood products. We had a surgeon operating capability. One of the surgeons that we have is also kind of Iraq war veteran, and so is definitely used to some of these things. But again, some rural trauma centers may not have, they may have surgeons, but they're really not comfortable with massive trauma like this. It's just something they don't see on a regular basis. Amputation care, again, not a high priority, but again, once you start working through that, we ended up kind of getting the arm and got that to the hospital later, just to let the downstream physicians that would be considering reimplantation decide if they're going to put it on. In this case, it was not feasible. The patient was too critical, and again, just the nature of the reimplantation in this case. But again, one of those good things that we just talk about to our pre-hospital providers, and kind of working through all the steps for an amputation. So looking at the actual timeline, so about 8:29, the 911 call came in. 8:42 was when Battalion 5, or the incident commander, got on scene that you heard about. Medic 10, the ambulance, got on scene at 8:43. About 20 minutes later, the helicopter was on scene. Again, we talk about kind of the load and go mantra for trauma patients with scene times less than 20 minutes, but we were doing active resuscitation in the ambulance, getting lines, getting blood products, waiting for the helicopter. So again, it's those decision things. You don't always sometimes make the best decision if you're following the exact algorithm, and so again, having some of that medical decision making, some of the flexibility of kind of working through and some of your reversible life threats. The helicopter was en route to the hospital at 9:47, and then 9:55 the helicopter was there. As the patient was in the helicopter, as they started getting the blood products, starting to get more bleeding out of that wound packed area, and again, just showing that some of that perfusion was being restored. So at our hospital at St. John's Health, a patient came into the emergency department. Here's an x-ray. They empirically put in a chest tube, just anticipating kind of massive lung injury, pneumothorax injury. This is all additional wound packing after the initial damage control resuscitation surgery. And so again, you can see the staple line here. You can just see they did massive packing of the wound. Again, minimal OR time just to get them to the ICU so where they can do the ongoing resuscitation once the bleeding's been controlled. We used all the blood products that we have at our hospital, so that's 22 units of packed cells, 20 units of FFP, and a 10-pack of cryo, and then basically we don't have platelets at our facility, so it didn't look like the patient was going to survive well. Went back to the OR again after they started going into DIC, or disseminated intravascular coagulation, was having blood come out of the rectum. Again, went back to the OR just to make sure there wasn't a kind of unrecognized hemorrhage. They did exploratory laparotomy, make sure no other kind of acute bleeding sources could be controlled. The patient's father was actually a flight nurse, and so really understood and recognized, and so we did as much stabilization we could. Initially, the transport decision was withheld, thinking that the patient was not going to survive, but as they continued resuscitation, the patient actually was continuing to improve, so then we flew the patient to that level 2 trauma center, which is in Idaho Falls. It's about a 40-minute flight, and 3 weeks later, there he is. So again, kind of had need for dialysis, but ultimately kidney function resumed. Had ARDS, or significant lung injury, just with both the trauma as well as the resuscitation and feeding tubes. But 3 weeks later, he walks out of the hospital. So again, all these things that we sometimes do that seem like they're futile. Again, trying to pick which case makes sense to continue and go on through the next resuscitation steps. The patient came back and thanked the ambulance crew and the hospital crew, and then this is the patient a year later. And so kind of he's got a new functional prosthesis, and just amazing kind of resuscitation story when you put all those, just like the cardiac arrest, just same thing for trauma, all those little pieces together. And if there wasn't a kind of initial response, initial bleeding control, optimization and resuscitation, helicopter coming in with blood products, getting him to the local hospital with additional damage control resuscitation surgery, and just moves through that whole trauma chain of survival. Comments, thoughts, questions? Yes? Is it microphone?
Great story. How do you teach your paramedics point of care ultrasound?
We're just working on potentially introducing paramedic ultrasound. I think the big question as a medical director is what additional decision making is that going to offer in the field, and the proficiency level to kind of make that decision, and whether or not that's kind of their acquiring the image and interpreting the image and making that decision themselves, or if you're using some component of like teleradiology, so pushing that back to myself or to one of the other emergency medicine physicians at the hospital. We're still working through that. The technology, the artificial intelligence, having the machine be able to help get you the image and then help you interpret the image so that the proficiency is easier to maintain at that level. So we're still working through that.
Yeah, I have a question about the very initial phase of the response and the hemorrhage control. He apparently didn't bleed out completely. Was it like that the people around him controlled the... Maybe I didn't pick it up from your talk.
Yeah, so the initial bleeding control, the initial responders, by the time they got him off the drill rig, his arm out of his coat, and kind of laid down to the ground, the first arriving units were there. There was, most of the hemorrhage had already occurred before that point. By the time I got into the back of the ambulance where they pushed him in there, there was minimal bleeding from that side. That started more in the helicopter once we got the pressure up a little bit more with the blood products that we gave at that point.
You mentioned in your talk that as you were giving the bleeding products that the clot started popping. Do you mind talking about what your protocols are in terms of titrating to a particular blood pressure, or are you guys just giving it full out, expecting that there are going to be clots that are busted?
So again, patient had no pulse, and so looking at the arterial line waveform later, had, and a little bit at that time, had systolic pressures in 10 to 20. So we really don't have like exact numbers a lot of times because we don't have that exact. So it's more a little bit of mantra. We know with head injuries that you need a little bit better perfusion pressure because we know with head injuries and trauma, if you're not having the systolic blood pressure to a certain level, kind of 80, 90, 100 systolic, they have worse outcomes. So it's kind of finding that just right spot, but it's a little bit more nuanced. We don't have exact numbers that we're going on, but trying to, the permissive hypotension concept is what we teach.
Hi. Was the patient ever scanned at some level, or did he, when he started bleeding from the rectum, was he unstable as well?
He still was unstable, yeah, and so they went straight to the OR, but they ended up getting kind of a pan scan, so head, C-spine, chest, abdomen, pelvis at one point, and so that's when they found like the sternal fracture and things like that.
I was just wondering, how did he respond to positive pressure ventilation, and did you put in an finger thoracostomy?
So with the EFAST, we didn't see a massive pneumothorax, so we did not do a finger thoracotomy on scene. But again, if we would have seen that we needed to do that, we would have done that. Again, we were working multiple things and deciding which were the immediate life threats to put in the order of priority to treat on scene. They did the chest tube once he got to the hospital, but yeah, needle decompression or finger thoracotomy, if he would have had a positive EFAST with a pneumothorax, would have been indicated.
Thanks, Will. Great talk. Getting some flashbacks, really. In 2004, I attended a scene which was almost identical to this in someone who had an arm that was amputated in a recycling plant. The really strange, there were two kind of interesting things. One is they sent 2 ambulances, one for the patient, one for the arm, which was odd. The second thing was the lack of bleeding was really interesting. So at that junctional point where you mentioned, I think the catecholamine release was so enormous that actually, apart from some adrenaline soaked bandages, actually the patient almost bled surprisingly little. Had a similar course post-operatively compared to your situation, but back in 2004 they didn't have robotics, and I'm not sure they still do in Edinburgh, but really great case, and thank you very much.
Absolutely, thank you.
With him having that period of pulselessness, did CPR ever get started, or because of the ultrasound, did you hold off?
We were doing the manual CPR, so the Lucas device. So yeah, once we were not feeling palpable pulses, we still saw there was cardiac activity, but just not. So we were using manual CPR, or sorry, mechanical CPR to help optimize circulation.
Thanks for a great case. I just wanted to quickly ask, we've faced that issue before, where you're trying to get to a trauma centre but the distances are so large that you're running out of blood products that you want to give, and sometimes we've tried with varying success to get regional hospitals to bring blood products to the helipad and just take off without actually offloading the patient. Have you come across that? And one of the barriers we face is, understandably, the blood bank won't give blood products without patient IDs, or the patient isn't admitted to that hospital per se. Was that addressed in this case, or was it just decided to offload as soon as you landed?
Yeah, so we did not work through that step, but yeah, blood banks and having those things worked out up front are very important, because a lot of times blood banks are some of the most regimented, hard-walled. It's kind of like the DEAs that are worried about controlled substances and things. So we ended up having a surgical response as well as additional blood at the hospital, so they decided to kind of take the patient into the emergency department or A&E and continue the stabilization there. If it would have been at a more remote clinic without blood products, or a remote clinic without surgical capabilities, then yeah, I think your point of just getting additional blood products, stopping there, and then getting to where definitive, because you need to stop the bleeding. I mean, and again, it's all those pieces that just need to come together in that whole chain of care.
Thank you for an interesting case. When you're reviewing the case, is there anything that you've learned or reflected on that you would do differently in a similar situation?
Yeah, so looking back at the times on how long we were kind of in the ambulance and kind of how long till the helicopter got there, Those would be the points that I would try and narrow down as much as possible, because how much are we doing in the back of that ambulance that's totally benefiting the patient in that long chain of survival. So trying to minimize those times would have been something that I would try definitely kind of shorten down. The other response, I think we did everything that we could with as much kind of resources that we had. Would have been nice to have more blood products. It would have been nice to kind of have a couple more kind of things, but the time is what I would really narrow down. All right. Do you want me to do one more, or do you just want to switch over to you? Switch. Yep. Okay. All right. So there's my contact information, and I'll be around, and I'll do another talk tomorrow morning. So thank you.
Hi, can you hear me all okay? Right, so I'm not going to be introducing anyone, just me. So I think Mads is sorting out the slides. So I'm sure I know most of you already from previous years, but my name's John Chatterjee. I'm a consultant in pre-hospital care at the Royal London for London HEMS, and I'm also a consultant anaesthetist at Guy's and St Thomas's, and I specialise in thoracics, transplant and difficult airway management. So what I was going to chat to you is about two cases from my own past in London and my own practice. But what I'm most interested in is hearing what your thoughts are and what you would do. So in terms of interest and stuff, I've got nothing to declare. That's what I do for a living. So the first case was a day shift in London, and there were reports of a road traffic collision with a motorcycle versus car. So what had happened was that there was a two-lane road. The car was going to turn left, and the motorcycle behind didn't see that the car was slowing down and indicating to turn left, and just at about 25 to 30 miles an hour went straight into the back of the car, and the driver was thrown forward, hit the back windscreen of the car, didn't break the glass, and then slid off onto the ground. Okay. So the location, those of you that are familiar with London, this is just in East London, and it's not very far from the Royal London. So we went there by helicopter and landed just behind the incident. So we were there pretty much about 10 to 12 minutes after the incident had occurred, and by that time there was an ambulance on scene. So what I was presented with when I arrived was a young gentleman. He was in his mid to late 20s, and he had a clinically fractured femur but no massive blood loss, and he was GCS 14 to 15, just a little bit upset at the accident, but not agitated, not with a clear head injury. And I couldn't see any catastrophic hemorrhage or any immediate airway problem. There was breathing-wise, he said he felt a bit short of breath, and I noted he had some crepitus on the right-hand side of his chest. No, sorry, on the left-hand side of his chest. And circulation-wise, he had a reasonable radial pulse. He was cerebrating. And in terms of other injuries, he just had this isolated fracture to his left femur where he'd come off and hit the back of the car. So, over to you guys. What do you think is going on? What are your priorities? Would I consider? Yes, absolutely. I mean, yeah, if you think he's potentially got a pelvic injury because he's, yeah, motorbike versus back of a car, and he's also got an associated lower limb fracture. Absolutely. What do you think's going on? What do you want to do for this guy? What are the diagnoses you're worried about? Chest injury? Yep. So what would you want to do for the chest injury? Yeah, sorry, I'll just give you the microphone so the people at home doing their dishes can hear.
You noticed crepitus. I would be worried about chest injury, and therefore either use an ultrasound or more clinical skills to.
Quite agree. So I popped an ultrasound on, and he had good lung movement on the on the right-hand side of his chest, and on the left-hand side of his chest, where I could feel a bit of crepitus, there was indeed loss of lung sliding. So what would you do? He's GCS 14-15. On oxygen, he's got saturations about 96, 97.
That was what I was going to ask. Like, what were the sats? And
so the sats are about 96, 97. He's a bit tachypneic. So what would you do next?
Depending on how far the hospital is, you would, at this stage, well, you're obviously very suspicious of him developing, either a simple pneumothorax or a tension pneumothorax. And just from the mechanism of injury, usually where you can suspect aortic dissection or all that stuff.
So
but
is that microphone on? Just sorry, I can hear you.
I'm sorry, I will talk like this. With this mechanism of injury, you just think of the big five of intrathoracic trauma.
Absolutely.
But as long as he's quote unquote stable, which he probably isn't.
What would you say? I'm going to give you a tough case.
Well, you would join him to a level 1 trauma hospital where they could give definitive treatment, and depending on how his vitals sort of evolve usually in the 10-15 minutes that you attend, you can already see, is this going sort of horizontal, is it going downwards, or is he improving even?
Yeah, I think that makes perfect sense. So that's exactly what we did. So keep the microphone, because I'm going to come back to you on this. So we as suggested by the chap in the back there, we rolled him to put a pelvic binder on. We put a splint on the leg to traction the leg. That sort of reduces pain, reduces bleeding. We got some IV access. That whole process took, from getting him off the road and onto the stretcher, probably round about 10 minutes. And in that 10 minutes, those initial sats of sort of 96, 98 on oxygen started trending down towards about 93, 94. Still reasonable GCS, but now, a little bit more respiratory embarrassment, a little bit more tachypneic. And in terms of location, so we're lucky in London. So we, once loaded on the ambulance, we're about 12 minutes from the nearest major trauma centre.
Yeah, that may still be a bit too long. So you may just want to prepare for worst case scenarios. You should just do a small kit dump for emergency thoracostomy, sedation, because it's quite unpleasant if he's still half awake and developing a tension pneumothorax. So you just prepare for setup for those type of things, so you don't have to rush and get into your pack when it's happening.
Yeah, I'm in agreement with that. Is everyone else in agreement? Anyone think this is crazy stuff that we're talking here? Cool. So this is exactly what we did. What would you sedate him with? So we've got the usual range of HEMS drugs available, and so set up to do a sterile. So we have the option of either doing a finger thoracostomy or a chest drain. So in my service, we say if you're not going to put the patient to sleep, then a chest drain is preferable. But we say you should do a chest drain when you have an isolated chest injury, not as part of a big polytrauma. But I kind of pushed the guideline a little bit because of saying that it's just the leg and the chest there. So we're set up for that. But what would you want to sedate him with? Oh, sorry, pop your hand up. It's not. I can hear you, but it's just so the people at home can hear what you're saying, so they don't think I'm just making it up.
Maybe a bit of ketamine.
Yeah. How much would you say? Say 27-year-old guy.
I don't know off the top of my head.
Any suggestions? 10? Yeah. So start 10, 20. So I sort of started with 20 with him, and sort of just gave him a minute or two just to settle down, cleaned up the side of the chest, did a finger thoracostomy, and then placed a chest drain in. So had a little bit of release of air, not a huge amount. Sorry, just the TV thing. Not a huge amount of air, but a reasonable amount of air released, and the chest drain went in nicely. And so I was quite happy with that. And so then I came to reassessing him. Just before sort of thinking, I've done that, and let's pop off. So again, no catastrophic hemorrhage. Airway, well, he didn't respond from his airway and breathing. He didn't kind of do what I expected him to do. I thought, personally, thinking that we're going to do, I found a problem, I fixed this problem by putting the chest drain in, he should get better. But he was still fairly laboured in his breathing, in fact getting more laboured in his breathing. And there could be a couple of reasons for that, but I'll ask you why. And his saturations were now 90. Circulation-wise, he was getting a bit more tachycardic now, and the blood pressure was beginning to slide a little bit. Now, and disability, nothing had changed, but any thoughts on why this might be? Over there.
Could he have a fat embolus?
What?
A fat embolus.
Possibly. What do people in the audience think about that? Fat emboli, we're talking sort of within the first hour after injury here. Very definitive from Tatiana. That was a no. Would you care to expand?
Thank you. It's a possibility. It's a long bone fracture, but from my little experience, they occur a bit later on.
Yeah, I think it's more an inflammatory thing, but you could have an air embolus if I've managed to nick something or get my chest drain wrong. But I was fairly happy with where it had gone in. Any other reasons? I mean, I've just given him some ketamine, I guess, over here. Oh,
he's bleeding.
He could be bleeding. I could have. I'm probably not supposed to. I could have effed up and just missed something here. So this is where. I'm really fortunate in the service I work in London, is that we have a really strong relationship between the paramedic and the doctor. We try to maintain equity. There are things that they do better than me. There are things I do better than them. So this is where I sort of look up and go, do you want to have a quick check and make sure I haven't screwed up? And it's like, no, the pelvis still seems intact, but there might be occult bleeding, something into the abdomen, and certainly that could be it. And what were you thinking? Sorry, just there.
Just thinking with the tachycardia, did you consider contusio cordis? Was there any electrical alternans? Any heart trauma?
So the ECG looked normal, slightly low amplitude, but to be honest, when I'm looking on scene at these sort of things, the ECG, to compare, I didn't do a 12 lead. I probably could have, but I didn't see anything gross, the abnormal on the ECG, on the rhythm strip on the monitor.
Yeah, maybe you mentioned it, but did you check the other lung again? Maybe.
So I did check the other lung again, and I thought maybe I've missed something there, because ultrasound sensitive, but it's not the end all. Someone in the back there? EFAST. So I would have loved to have done an EFAST in this chap, and I couldn't, because in those times we carried the ultrasound with just a probe for vascular access, so it allowed me to look at the lungs, but not the abdomen. But I'm going to give you the magic of 2022 back to then, and so if we did do an EFAST, it would have been negative. A tamponade. So if I looked at the heart, I wouldn't have seen an obvious tamponade.
So I was just thinking, is this potentially a bleeding mimic for TBI?
A bleeding?
Mimic for TBI?
It could be. It could be. So where I went to, I thought, look, do you know, I think I might have over-sedated him, might have screwed that up. I think I might be missing some stuff. And I would love to say I was as good a physician to have thought of all of your suggestions, but I thought of some of them, and I bounced them around, but I couldn't find an obvious answer. And you know, spent a couple of minutes doing that, and I looked at him, and he was now SATs of 87, 88, labouring his breathing, and his GCS wasn't coming back up the way I would expect it to after a single dose of ketamine for the chest drain. So what would you do next? What should I have done next? I'll be honest, at this point I was feeling a bit shit. I was beginning to think this is one of those things where the case is sort of moving on faster than my brain is, and I'm beginning to lose control.
How far are you from the hospital?
So we're still 10, 15 minutes from hospital. So we still have the option of bailing out and going to hospital. Yep.
And how long would you do for a kit dump and RSI of this patient? And
can I ask you to give the microphone to Mike at the back there? And he will tell you, he's one of our HEMS paramedics, and he'll be much more honest than I am on how long it would take me to do an RSI.
Just for reference, I don't know anything about this case, so I'm in the dark as well. But to start off with, radial pulses and blood pressure, where are we at the moment?
Blood pressure is starting to drop now. So we're now in the mid-90s to high 80s in the blood pressure, and pulse is going up.
So I'll probably be suggesting to John now to possibly make him a code res and start giving him a transfusion. I'll be worried about possibly putting him off to sleep with a low blood pressure, with that bit possible pressure ventilation, so potentially give him a pod product. And to answer your question about an RSI kit dump, if I'm honest, hand on my heart, probably about 2 to 3 minutes.
Yep. So I've got someone who's becoming hypoxic. So in my mind, I was thinking hypoxia could be the cause of all of this. Maybe I've just missed the right side. I don't want to put 2 chest drains in. If I'm going to do a thoracostomy on the other side, I should probably just take the drain out and do bilateral thoracostomies and put my money on the chest. I thought I could be bleeding, in which case I was thinking if I fix the chest and exclude that, then I can go on to giving blood. But I've got someone who's getting hypoxic here, and if I don't do anything, I think I'm going to get in trouble. So I thought I should do a low-dose RSI and just get some oxygenation into him, and then make a hole in both sides of the chest and just exclude the chest injury before going down a bleeding route. But what do you guys think?
Have you considered a tracheobronchial rupture?
A what?
Tracheobronchial rupture.
Oh, bloody hell, I'm not that bright. I should have, but I'll be honest, I didn't. But that's a good idea. But the reason, I'll tell you the reason I didn't, sorry, I'm being facetious about myself. The reason I didn't consider a tracheobronchial rupture is we're talking a 20, 30 mile an hour impact at most. He would have braked before going into the back of the car, and the car was slowing rather than stopped. So the actual deceleration would probably have been about 10 to 15 miles an hour, and it wasn't even fast enough to him to break the windscreen at the back. So I usually associate tracheobronchial rupture with a much higher speed RTC and rotational forces, but I didn't think about it specifically in him.
But at this point, I think the patient must be bleeding. So, I mean, you didn't have a fast, so maybe at that point, it could have been possible the abdomen. If you had a fast and it was negative, the retroperitoneum would still be a place because it would not show on this fast scan.
Yep.
And the patient had enough energy to break a femur on a young man. Yep. So I would be thinking on something that is broken. Of course, I would consider pelvis, and the binder would be placed as well. And blood, I think at this point, on top of, maybe you need to do something with the oxygenation, but I would not do one or the other. Maybe I would do a combination, and blood plus airway management.
Cool. Okay. So, yep. Thank you. So let's say we go exactly down that. I think that sounds a sensible route. So we start some blood, and we do a kit dump. So in that next 5 minutes, we've got the blood started, going through large bore peripheral IV access, and we have a kit dump set up to RSI. Decide to go for a low-dose RSI because I've got a lowish blood pressure and I'm considering bleeding. So I go for a 1-1-1 anesthetic. So this is 1 microgram per kilogram of fentanyl, 1 milligram per kilogram of ketamine, and 1 of rock. So fairly low dose, generally doesn't affect blood pressure too much. So what happened then is I put the laryngoscope in to have a look down, and I couldn't see anything. I could, but I couldn't see what I wanted to see. So I didn't have Jackson Hole. Sorry, that's a terrible joke. I didn't have a hole to intubate. What I had was just pink froth everywhere, just pink froth coming up and out of the airway. Did someone say shit? That's exactly what I thought. So what the hell's going on? This could be neurogenic pulmonary edema, or a tracheobronchial rupture, lung contusions.
It's not blood, it's froth.
It's froth. It's pink froth. So what do you do, though? So look, I'll tell you what, I stuck a sucker down, and I put a bougie down where I could find the bloody hole and feel some corrugations, and I shoved a tube down there, and then I connected them up to the bag valve mask. Sorry, not mask, the bag, the self-reinflating bag. And it was really hard to ventilate them. So I passed it off to my paramedic, who has bigger muscles than me, and I took a blade, and I said, I cut out the chest drain, put my finger in, could feel lung on the left side, and I made a hole in the right side, and I had no release of air, and I could feel lung on the right side. What next? Yep.
If you had an ultrasound,
yes.
would you throw it on the heart again?
Yes. Yes, if I did, I would have. And so if I had thrown the ultrasound on the heart at that point, I would have seen a poorly contracting, failing heart. So, what I did in reality is I thought I better phone a friend. Some of you might have heard of Gareth Davies. He's one of my old bosses, and he has as much experience as Mike, and is an incredibly bright guy with a huge amount of thought. And I said, Gareth, I'm just going to present this case to you, what I've done step by step, and I'm not sure where to go next. So what do you think he said to me? Because you are the collective hive mind here. Coronary artery dissection? Go to the hospital? He did say go to the hospital. But he had another question about going to the hospital, because the question is like, so there is the thought process of, I just want rid of this patient, so that it's someone else's responsibility. But the other question is, what do I want from the hospital? So those of you that have been around London know that, which is is it that button for the light? Yeah, cool. So those of you who've been in London know, so that's where the incident is. This is a Royal London Hospital. The Royal London Hospital does not have on-site cardiac support. They have trauma surgeons, but for ECMO or any sort of cardiac bypass and support, that's at Bart's here, which would need about 45 minutes, an hour to get them across. Just across the river here is King's College Hospital, which does have on-site cardiac support. So what do you do? Go to King's? Yeah. Why? What do you want from them? If I'm the King's A&E consultant, and you're phoning me saying I'm going to bring someone from the other side of the river to you, you know how taxis are. What the hell do you want from me? Why do you want to bring him here? Take him to the Royal Bloody London.
Primary cardiac event.
And I want them to do something to the heart. So,
were you able to ventilate now after you?
No, I found it really, really tough. I put him on the ventilator, and the ventilation pressures were alarming. I went up to a peak of 55, 60 just to move about 150, 200 mils, and I put PEEP on as well. So at this point, I thought I'm not going down the bleeding route here. I'm going down a myocardial contusion route. Yep.
Did you try giving some adrenaline?
Not initially. I did a little bit later on as his cardiac output dropped off, and it made a little bit of difference for a short time, but not a huge amount, sadly. So, yeah, I think. So what we did was we said we're going to go to the Royal London because we are closest there. It's a 25-minute journey versus a 12-minute journey, and I was going to lose this patient in the next 5-10 minutes regardless, because everything I was doing wasn't working. So we started CPR en route. I elected not to open his chest. I didn't think there was going to be any benefit from it, and elected just to go at that point. I didn't think there was anything else I had in my armory that was going to make a difference for him. When we got to the Royal London, we had a very, very good reception with trauma surgeons there. They did elect to open his chest. They found a normalish looking heart, no tamponade, no blood in the chest, nothing else to go on. And he died, sadly, about 15-20 minutes after his arrival at the Royal London. So one of the things we do in London is we are allowed to attend the post-mortems of our patients to see what happened, to help us understand, and also to feed back. So his injury that killed him was a myocardial contusion. So that flat slap against the back of the car basically cooed and contra-cooed his heart and gave a myocardial contusion, which took around about half an hour to develop into fulminant heart failure. He was bleeding. He had a small renal artery tear, but because of the myocardial contusion and the lack of significant cardiac output for long enough, that only collected about 200 mils of blood in the retroperitoneal space, hence the fast would have been negative. And he had a small liver laceration, which was more incidental in finding, and the fractured femur that we expected. So if he had gotten to hospital, if he had gotten onto ECMO, those other things would have played a role in his ongoing treatment, and certainly if he'd gone onto ECMO, the coagulation would have been an issue for that. The frustrating thing is if I hadn't gone to the post-mortem, in our system in the UK, this simply gets certified as polytrauma, and that's all. It doesn't go any further. But I found this could be quite a nice case to learn from and reflect on. Now, you have a choice. I'd like a show of hands. So we are almost at the end of my time. I could do one more case try and do it in 10 minutes, and then that will eat into your skiing time for 10 minutes. And Mike will go on after, if that's all right. Or do you want to go skiing? If you want to go skiing, put your hands up. Otherwise, I'll crack on with another quick one. All right. Okay, you guys feel free to go. It's fine. It's not a problem. I won't be offended. Okay, another quick one, and I'll go faster with this one. So there's a medic 2 shifts, there's a night shift, road traffic accident, a black taxi, which you would have seen in movies if you haven't been in London, versus a 55-year-old adult, very low speed again, minimal damage to the car, literally just a dink on the bonnet, and we were initially given that the GCS was low, and that's why we were sent, because he was initially said to have be unconscious, and then a low GCS and confused. And then when we got there, he was improving. Right? So any thoughts on what you think's happening to him? What do you think? Why do you think his GCS is low? Why do you think it's improving? Anyone come across impact apneas? Yeah? So I thought this guy had an impact apnea. Quite commonly found that you have a medium to low force to the brain. The patient stops breathing. That's the initial 911, 999 report that this patient is not breathing, and hence you dispatch advanced resources. And then when you get there, they are breathing and things start to normalize. And the impact apnea, sort of you see a dysregulation in the physiology, and that slowly returns to normal after a few minutes without any underlying brain injury. And the length of that dysregulation is dependent on the force and then the patient's underlying conditions, where they've had alcohol and things like that. So alcohol drops your threshold for that. So when we got to him, I had a quick look at him, and he was actually okay. His airway was patent, and he was breathing, and he was slowly starting to improve, and I couldn't really find much else wrong with him. So I looked at him and I thought, do you know what, I think this is a resolving impact apnea. So would you want to do anything for this chap? Would anyone want to do anything? So for those at home, the suggestion is just he just needs to go into hospital, doesn't he? He's improving. Let's take him to hospital. I thought, yeah, I agree with that. Let's just load and go to hospital. And as you will not be surprised, I had that horrible sinking feeling as we were travelling to hospital of I think I've mucked up again and things are not going right. So as we're going into hospital, everything else seems fine again, but his breathing starts to not be so great, but not a massive problem. But what I find is his blood pressure is just dropping on me, and he's becoming tachycardic, and he's becoming less responsive now. So what would you want to do for him now? You're en route to hospital. You've got 10 minutes before you get there. Not that I could see, but he's an older guy, so, you know, you've got the silver trauma stuff, you could have some sort of occult bleeding and stuff. But yeah, I reassessed, and I couldn't find anything obvious, and I didn't have e-fast ultrasound, but we're in a moving vehicle as well at the same time, and I sort of felt I didn't want to stop to do anything at this point. So do you have your hand up? Oh, well. Any other suggestions? Anything else? I don't know. I didn't have any history of that, but there's a certain potential given that he's in that age group in his sixth decade of life. I mean, I thought I probably missed some bleeding here. The chest sounds okay, but his blood pressure's dropping and he's becoming more tachycardic. So, like the last case, I thought, let's just give him some blood. So gave him some blood, took him to hospital, and he died. And I was like, I sat down and I thought, what the hell have I done wrong? I don't get it. This guy should have been better. He should have fixed himself from the head injury. And I was like, well, he didn't, looked at the post-mortem, he didn't have a cerebral bleed. I thought, have I missed something in the abdomen? He didn't have an abdominal bleed. What do you think killed him? So these are tough cases, and I took a long time thinking on this, and I spoke to the coroner and stuff, trying to figure out what had happened. And these are tough. These, you know, the answers don't present themselves. But when you have an impact apnea, when you have a brain injury, you get a sympathetic surge along with it. But for me, the majority of the patients I see with a brain injury are young, and so the sympathetic surge is easy for them to tolerate. But as you pointed out, he's an older patient, and this sympathetic surge just tipped him over into a massive MI. And I looked back at the ECGs, and hey presto, there was my ST changes that I just completely missed because I was focused on a head injury. And those ST changes are what killed him. Anyway, enough from me. I'm going to give you over to Mike. Are there any questions or anything? Cool. Otherwise, I'll happily chat to you at the bar.
Okay, so let's get my slides over. Is that well? Oh, hold on. Okay, we're going to talk briefly about a case I was involved in, and actually I've seen these on several occasions. Patients spitting up blood. Now, as I reflect on life, I've had a lot of experiences, and three things really scare me. The first is an engine failure in a single-engine aircraft. I've experienced that twice in the military, luckily walked away. Second, nuns. I went to a parochial grade school, enough said. And the third is post-tonsillectomy hemorrhage. Very early in my career as an EMT, I was called to transport. And this is 1978, so again, I'm a basic level EMT. I've only been an EMT for a month or two. were called to transport a post-tonsillectomy hemorrhage. He was evaluated at a regional, very small hospital. In those days, they didn't have emergency medicine. They just had any moonlighting MD or any staff physician. And the guy basically said, this kid's really bleeding. He had his tonsillectomy in Youngstown. He needs to go there. Kid's agitated, so he gave him, his only treatment really was a bunch of Valium, and the bleeding had stopped. But long story short, we transported him. About halfway there, starts to get agitated, comes out of it. He uncorks, and he just bleeds. And it's just me in the back of the ambulance. What am I going to do? You know, I have suction. We have no real drugs, no airway. But bottom line, he died en route. And that really haunted me. You know, it's one thing if you're older and you understand what went on and you knew that, yeah, you did all you could or you should have done this, but, you know, it really haunted me. It made me reevaluate, you know, am I really cut out for this medical stuff? But let's fast forward. So post-tonsillectomy hemorrhage, it is a brutal lesson in hemostasis. Tonsillectomy is the ultimate test of hemostasis. When you look at the tonsils, you know, they have this incredible arterial supply from 4 different sources. And, you know, to surgically remove those, you know, it's pretty tough stuff. This is a picture of one is where they removed the entire capsule, but this is what it looks like basically. In the typical healing, within 24 hours, you have a fibrin clot on the tonsillar fossa. It proliferates, and day 5, you get this thick cake. And if you've ever seen it, it looks like hell. And when adults, it's bad enough, as children tend to do a lot better. But I remember my daughter had a tonsillectomy at about age 19, and oh, what a miserable thing. So the mucosa starts to grow from the periphery and grows inward. And then the clot begins to separate from the underlying tissue at 6 to 10 days. But this is when secondary bleeding is the highest. This is a picture of, this is very typical healing. Day 1, day 5, you know, you can see that mucosa start to grow in, and then day 17, things are evolved. But yeah, very painful, and typically there's no bleeding. So with post-tonsillectomy hemorrhage, the incidence is 3 to 5%. There's the primary bleeding, which occurs in the first 24 hours. And that's not due to the healing or anything. It usually has to do with something went wrong with the surgical procedure or something was not quite done right. The secondary is more common than the primary. Average time of the bleed is somewhere between 6 and 8 days post-procedure. 40% are preceded by a minor bleed, but a full 60% just uncork with no real sentinel bleeds. And 10% of all minor bleeds will progress to a major bleed. So what are the risk factors? It's typically older patients, patients with chronic tonsillitis, obesity, and obstructive sleep apnea. Any physical attribute which would complicate surgical exposure, someone with a small mouth where they just can't quite get enough exposure to do the procedure right. So the first question when you're evaluating these people is the patient actively bleeding, even a small amount? Because most of the time, they'll come in to the emergency department and they'll say, yeah, spitting up blood, it stopped. Okay, but is there active bleeding? So you'd handle this a couple different ways. I work at a couple different hospitals. At the major university center, 30-year-old male presents, 6-day status post-tonsillectomy, spitting up clots. Vital signs look good. On exam, he's oozing from one of the tonsillar pillars. Your next move, in this case, what would you do? Call ENT, yeah. See, that's one of the challenges of academic emergency medicine is to keep it from becoming a triage center. And that's why I like when I do, because I do full-time HEMS, and I do a couple ED shifts a month, and I like to work in rural and community EDs. So the exact same patient, and this is a community hospital, there's no ENT within 30 miles. You know, what are you going to do and what's your decision process? This is an algorithm. It's pretty good. Is there active hemorrhage? If there's not active hemorrhage, they say you got to sit on these people for an extended period, 4 to 8 hours. If they're still not bleeding, they need semi-urgent referral to ENT. But if they're actively bleeding, then you have this decision tree. And it really comes down to, are they going to tolerate a painful procedure? Because what you're going to have to do is get in there, hold pressure, and do a couple things which we'll talk. So if they are under 18, you know, they're really not going to tolerate it at all. And so they suggest here, if it's a child and they are actively bleeding, you know, they need to go to the OR with ENT if you have an OR. And do you see a focal source? If you don't, you know, they still need to go to the OR for evaluation. And if there is a focal source, there's a couple things you can do. So the initial treatment, again, this is in the emergency department. I have no ENT, assuming I have a semi-cooperative patient. You need a good headlight. You need a really good suction, and you're going to suction out clotted blood. And that's assuming the patient is going to cooperate. You know, you're going to give them a dose of analgesic beforehand. McGill forceps, you get a wad of gauze, and then you're going to soak that in, I'll show you in a minute, hemostatic agents, and you're going to apply pressure to the bleeding, but you're going to apply laterally, not posteriorly, because you want to get things stopped. So you can use epinephrine, lidocaine with epinephrine. They have the hemostatic agents, a little piece of gel foam, Surgifoam, Surgicel. And then they also talk about giving systemic TXA and also topical TXA to see if that will get the bleeding stopped. So let's fast forward. I'm on shift, and we get a call from Baraboo, a small hospital about 30-some miles, and the only report we get is a 16-year-old with some post-tonsillectomy bleeding. Vital signs are good, SATs are good. And right away, I get cold and clammy. I have PTSD. It really, you know, still 40 years down the pike, it still haunts me that that kid died in front of me. So distance about 32 miles, so by the time we take the helicopter out, get started up, fly up there, it's going to be a half hour or so. So we have this 16-year-old male. He's a good-sized kid, otherwise healthy. We arrived 25 minutes after the initial call. He's 7 days status post-tonsillectomy. He's from the Chicago area. They're up in the area vacationing, and he's done fine. He's had no complication. His throat's feeling better. So the sudden onset of bleeding about 2 hours before, and he starts spitting up a lot of clot. And then as we're en route, we get a call. They called our dispatch. They said, can they hurry up? This guy's uncorked, and he's bleeding quite a bit. So we arrive on scene. And how many people here work HEMS? You know, when you land and you offload your cart and you walk in the ED and you look around and all of a sudden you see this, the deer in the headlight. Where's the patient? And they just point, oh, that room there. It's like, oh God. So we go into the room. This kid looks like something out of a zombie movie. He's sitting up. He's spitting up and vomiting clots into an emesis basin and bag, has blood down the front of him. I'm looking at his vital signs. His blood pressure is about 100 over palp. His heart rate goes anywhere from 140, and then when he vomits, it goes down to 40. So, you know, this is bad. And right away, me, and unfortunately with a very seasoned flight nurse, we recognized we have a very time-dependent lesion here, and we're going to have to intervene. So the treatment thus far, they had 2 large bore IVs. They had given him some saline. They had given him a bunch of Zofran. They gave him a dose of TXA and some Ativan to calm him down. There's blood everywhere. I mean, this is a mess. So where is all the blood going? Well, he's obvious. I can see 2-3 units of blood sitting in front of me. The other thing, he's swallowing blood, and the second it's hitting his stomach, he's vomiting it back up. So, you know, it's regurgitated, and yeah, it's a mess. So, current data, fatigued, hypotensive, tachycardic, SATs are going okay. His initial hemoglobin is 12. So we'll call back up, call anesthesia, ENT. No, there's no anesthesia, there's no ENT. There's a moonlighting ER doc who has far, far, far less experience, and he's just hands off. He's almost in tears over this situation. Again, just as I said before, no one is coming, and this one is all on me. So first of all, suction. As I said before, these Yankhauers, these things over here, they're absolutely useless. The larger bore catheters like the Ducanto or the Big Stick, those are nice, but even those were clogging with clots. So what we ended up doing is just giving him the suction hose to hold, and he would spit into that. In the meantime, we got a lot of other suction ready. We had 2 suction units with large bore catheters. So what are we going to do? I'm going to have to control his airway. There's no way I'm going to be able to even get close to this or to stop this bleed. We're going to have to control the airway before we do anything. So we could do an awake intubation, a delayed sequence intubation, RSI, RSA, rapid sequence airway. And then this comes into play. What are my weapons? Am I going to do video laryngoscopy versus direct laryngoscopy? And why is that an issue? And we'll talk about that in a minute. Define duties and define teams. Fortunately, I had my flight nurse. We had a really good respiratory therapist, a good nurse. So, with video laryngoscopy and RSI, what's my problem with this one? Yeah, it's going to become occluded, and I'll go into that. Yeah, this. So here I am with my CMAC. But this is the business end of a CMAC, and it's not very big. It's just 1 to 2 millimeters, about as big as that dot. So 1 drop of blood, and I lose all visualization. And if I'm using a hyperangulated blade, I'm screwed because I have no other options. Things just go to red. But fortunately with my CMAC, I have a regular geometry blade, and I'm thinking, okay, if I lose visualization, I just shift over, and I still have direct. I can still visually see things, and of course, I'm going to use a bougie. So I've decided, okay, I'm going to do RSI, I'm going to do video laryngoscopy, standard geometry, with a bougie, and what drugs? Boy, this guy, I want something pretty fast because he's sitting up and he's keeping his airway okay as long as he's sitting up. But this is brisk bleeding. So I don't want to take a lot of time. I want him to go down fast. And I've got an assortment of things. There's ketamine. We use a lot of etomidate in these situations. So I elected to use etomidate and rocuronium. Those are going to be my drugs. And then secondary airways. If I can't intubate them, I've got to get an airway on them. So a couple different things. We carry the eye gel. I like that a lot. And I've really found that even in situations like that, you can get an adequate seal and protect the airway. And I've had situations where a King LT here, the pharyngeal balloon actually tamponades the bleeding. So that's a possibility. And then just thinking down the road, again, if I can't intubate him, if I can't get a good secondary airway, I'm going to have to do a surgical airway. And you've all seen the vortex. And I have my flight nurse, and she knows to remind me that, if I can't intubate him, you move on. You don't get stuck and fixated on one step, and you keep on moving down the vortex. But this is very true. Shared mental model. Don't surprise your partner with new techniques. Again, that's when I'm doing the surgical airway, or I'm doing this, I actually mark the trachea with a Sharpie, and that lets everyone know that, yes, a surgical airway is definitely, a possibility. And I borrowed this slide. This is a great slide. This is from the late, great Dr. Johns Hines. And he was talking about a shared mental model. And if you look at that, Batman was not included with Superman's shared mental model. He's a bit surprised by the whole situation there. But again, having other flashbacks. Early in my career, we used to see a lot of pediatric epiglottitis. And that's a horrible thing. I mean, we'd see kids in respiratory distress. I watched young children die from nothing but a lack of an airway. This isn't a polytrauma. This isn't some sepsis or anything. All they need is a piece of plastic in the airway in a day or two in the ICU, and they're going to do fine. But if you don't get it, you know, they're going to die in front of you. So I have to secure an airway. There's just no other option. There's no one. And I tell you, you know, that's sort of a scary and very lonely feeling. So, brief everybody, okay? Let's roll. So the first step, we had, again, all of our equipment ready. We had suction, 2 large bore suction. The nurse pushes the drugs, pushes the etomidate, pushes the rocuronium, he goes out. So the first thing we do is flop him back, 2 large bore suctions in the oropharynx. I get my laryngoscope, I take a look, and sure enough, I can see the left tonsillar pillar, this arterial bleed. And I can see cords, and I've got my bougie, this is great. All of a sudden, boom, everything goes to red. But again, I planned ahead. If this was hyperangulated blade, I'd be screwed. But again, I was thinking ahead, so all I do is just shift my vision to the right, and I can still see cords. So I immediately sink the bougie, railroad a tube over that, I inflate the cuff, and surprisingly, no blood out of the tube at all. We push a dose. I think after that, we gave him ketamine to sedate him. And SATs came up, good breath sounds bilaterally. You know, the tube looked good. We had end-tidal CO2, nice purple waveform. Whew, okay, I can take a breath. But in that short period, I can already see blood welling up in his mouth. So the patient is still bleeding. What next? You know, this is a piece of cake now. The hard part is doing this when you don't have an airway. Now that I have an airway, you know, I can see the bleeding, so we suck things out. At this point, I don't have an electrocautery or anything, but I use hemostatic gauze using one of the large suction catheters as a sort of a rongeur. I just pack the hell out of the oropharynx and sit back and watch, and sure enough, no blood. So we've stopped the bleeding. Whew. Okay. 8 minutes. Again, going through the PTSD of dealing with this. You know, at this point, I need to take 5 minutes. I go out in the ambulance bay, clean out my underwear, and have a cigarette. Come back in. We get the patient packaged and stabilized. This was my heart rate during the procedure on my Apple Watch. So at this point, things normalized. We had him on a ketamine infusion. Vital signs remained normal. Flight back to Madison was unremarkable. There we had ENT waiting for us. They imagined, I guess I didn't give the greatest report coming back, and they still imagined this kid was actively bleeding and didn't have an airway. And you know, I never like having surgeons on the helipad. It's like, I'll bring the patient to you, don't worry about it. But anyway, so they were waiting, and they were quite relieved to see that we were stabilized and he was no longer actively bleeding. But the most important thing is we had the airway controlled. And then for them, it's a piece of cake. You know, the kid's already intubated. They take him to the OR. They can find the bleeding source just with an electrocautery, Bovie. He went to one of the surgical floors, and I believe he was discharged within 24 hours. His hemoglobin had dropped as low as 8, so he lost a lot of blood. And this is just a link to the operative management of post-tonsillectomy hemorrhage, but it's a very different animal, you know, from an ENT in the warm confines of an OR with anesthesia managing these acute bleeds versus, you know, you as an emergency physician or a HEMS physician. You know, again, summary, you know, kids aren't going to tolerate any interventions. I have had this work using direct pressure with topical agents, was able to stop the bleeding. So, you know, that does work. Timely available of ENT, I said if they're available and you have an OR, this really is not a big deal. Are they actively bleeding? Do they have a history of bleeding? The patient's level of cooperation and his age. And early decisions. You know, I've had situations where I've picked these patients up and not worry about, you know, the sending physician, no, just go. Don't take the time to intubate them. They're not bleeding. But I know I've got an hour in the helicopter with them. So I'd rather err on the side of controlling the airway first. And so once you have the airway and they're bleeding, it's not a huge deal. And then, yeah, what is your time and distance to definitive care? It is just, you know, a short ground run versus, you know, I've taken these things, you know, 1 hour flights. And a big thing, the skill set of the transport team. Again, fortunately, this doc had, in our area, in the United States, the majority of programs are staffed by nurse paramedic. And depending on skill levels, you know, he was lucky enough to have, you know, myself as an attending HEMS physician to come in and take this patient. I think if you would have sent it, you know, by, you know, other means, it could have been a very different outcome. But yeah, it's a quick summary of all this. Any questions, briefly? We're doing really good on time here. Any questions on post-tonsillectomy hemorrhage? Okay, well, one back here, okay.
I was just going to say, sometimes in our service we use silver nitrate sticks if you don't have electrical polarization, and that has worked pretty well in the past. Have you any experience with that?
Yeah, so that's another option. Again, if you have a cooperative patient, you're doing an exam, you see a little bit of oozing, yeah, certainly silver nitrate is a possibility, yeah. It's not going to stop this kid. You know, again, I did not see the bleeding until he was knocked down, paralyzed, and I was ready to take the airway. If I would have tried to look, yeah, I would have seen just this arterial spurting, which, you know, you're not going to control it in any other way. Yeah.
I had a similar case that ultimately we were able to get stasis, but any use of a Foley catheter and inflating the balloon to be able to get some lateral compression in the airway?
Lateral compression, you mean once they're intubated? Yeah, there's a couple different things you could do like that. I haven't used a balloon, but again, I found that, again, once the tube was down and the airway is secure, you can really, you know, again, pack things with hemostatic agent. And at that point, even if I didn't stop the bleeding, but even slowed it down a lot, I'm okay, because, you know, the main thing that's going to kill this kid in the first few hours is lack of an airway. There's some literature out there, and they talk about exsanguination, not as common, but when people die from this, it's usually lack of airway. Yeah.
Yeah, when you talk about doing the RSI, it really gives me the shivers, just like you felt as well. I wonder, if I found myself in that position, I would think about doing it like a DSI and trying to keep him on spontaneous respiration as long as possible, just because I'm afraid to take his breath away entirely. Although I just want to know what you, as an experienced guy, what kind of considerations did you do when you chose to do the RSI versus?
Yeah, so DSI in this, you know, the situations where I'll do DSI, say you have morbidly obese patient who you're intubating for a variety of reasons and you're worried about airway anatomy. In this situation, boy, I was just worried because once he is the least bit sedated, his ability to protect, he's actively bleeding into his airway and at a significant volume. And so once he's even just suppressed a little bit, he's going to lose probably that ability to protect things, and I'm not going to have, you know, DSI, you can sort of take your time and, you know, see how they do. You know, I'm afraid that I'm going to lose the airway right away. So I elected, by doing an RSI, I'm just going to go ahead, I'm going to take it, I'm going to knock this patient down and assume that, you know, he's not going to protect his airway. So, but yeah, it did pass through my mind briefly, but in this case, I think the RSI worked well. One more?
I've seen this, some of these patients. One time there was a lot of blood and I didn't see anything. But one small chest compression gave me a tiny air bubble showing me where the larynx was. So that helped.
Yeah, not so much in this, but I tell you, you know, that's a thing with epiglottitis. Again, back these horror shows that I saw back in the 90s, where you would take a look and it's just this angry red gelatinous mass that has no anatomy. And that the idea of pushing on the chest and you see a little bubble and you say a Hail Mary and that's where you put the tube. But yeah, that's certainly a possibility. But I've seen in this case to go ahead and insert an airway, the King LT airway which we had, probably wouldn't have been a bad idea, because you had that big pharyngeal balloon that would have occluded things. But nothing in this case, an ET tube is what you want because, yep.
Yeah, since the blood was the one that's obscuring your view, what if trying to put compression once the patient is knocked out and then proceed with the laryngoscopy would probably give you a clear view, or something that's not feasible?
So once he was knocked out, I tell you, when I took a look in there, I mean, it was just sort of so overwhelming. Again, if I took a look and there was, some slight bleeding, but regardless, whether I stopped the bleeding or not, I'm still going to put down an airway. So in this case,
I'm just saying that maybe it would help you in having a better look by
better
compressing,
look,
starting. I mean, from the beginning, having compression maybe would stop the bleed, and that was actually stopping your view, right?
Yeah. So that would be a consideration. In this case, again, it was pretty brisk, and I had a view there, at first on the VL, and so the nice thing about it was there was no delay. I mean, I lost visualization with VL, immediately shifted to DL, and again, a bougie is a great thing. Boom, got that down. But that would be a consideration, yeah. Okay, well, thank you very much. Again, have a great lunch. And what time back here?
5 o'clock.
So, what time?
So it's 5. Can you? Thanks. So it's 5 o'clock back here. Straight to the front if you want to do the central line workshop, and don't